Thanks. Sorry. Slide change.
Right?
So just very briefly, I think many of us recognize, but just to emphasize again, we are in a growing challenge around the number of displaced people globally, and then obviously in malaria endemic areas. And this population is only going to grow with what we know is increased conflict, increased climate change, and other reasons for displacement in the countries that we're working in. So just to note, one of the critical areas that we know we need better information in is data around where displacement is happening and how we overlay that with both our malaria data and supported ITN distribution and other vector control data. So just quickly to mention that UNF has just recently put together a series of reports that help overlay where displacement and malaria prevalence is happening. And they have these for all three regions. We're just showing West Africa, but they have this for West, Central, and Southern Africa. So we really implore country programs to look at this data moving forward. So just a little bit about what we've done to help raise the awareness on this global agenda. Over the past year, we've had 3 sets of roundtables that really help to try to bring together different actors to look at how we can address this problem, not only within the malaria community, but with our humanitarian relief partners and others that we know are needed for the conversation. So our first roundtable was at the UN Foundation last September that really brought together multi-sectoral partners. The second roundtable was at the Global Fund Replenishment meeting here in Nairobi in December, where we focused on how countries can include IDPs, refugees into their upcoming GC7 grants. And then the third roundtable was at the Vector Control Working Group meeting in February in Accra, where we really looked at what is the research questions from an academic standpoint, and what are the new types of tools that are needed to help address this growing problem. So we have now, from those 3 roundtables, a set of recommendations for both donors, country programs, and for humanitarian partners around how we can work better together to look at how we are addressing these issues. One of the other ways we're doing this is looking at what is the approved type of intervention that we would want to recommend as it relates to a particular humanitarian emergency. And so these are the type of activities that we're continuing to grow data on and look at other programs to build our knowledge base around what is the appropriate type of response based off of the emergency that we're responding to. Just to mention, within the AMP ecosystem, we have both a set of case studies that we've developed from 4 countries, and we'll continue to build out these case studies around how country programs have adapted their campaigns to address challenges. And then likewise, there is the AMP COE document that also provides guidance for countries on adaptations made for COE designated countries. So just to wrap up from what we've done in AMP, we will have consolidated reports from each of the 3 roundtables and recommendations to those donors, humanitarian partners, and country programs. We're going to continue this need for this multi-sectoral coordination that we know we need, that includes our humanitarian relief partners, and we'll continue to look at how we can support country programs to include this in upcoming Global Fund grants. Okay. Thanks again for joining. With that, I'm going to turn it over to Julius to talk about what UNHCR has done to support refugees in Uganda.
Thanks so much, Joe. Yep. Good afternoon, colleagues. I'm Julius Gasozi. I work with UNHCR in Uganda as a health sector lead. I just want to share with you our experience. And the team in Uganda can actually complement because it's been an integrated process. Okay, so for those of you that don't know Uganda, we Africa's largest host for refugees. We have 1.5 million refugees. And for the purpose of this discussion, 45% of the consultations in all the settlements is due to malaria. But globally, as you know, there is the Global Compact on Refugees, which ensures that refugees are integrated into the national systems. And this ensures that host countries have burden of hosting refugees, and development partners are supposed to support those countries to reduce the pressure on their healthcare systems. So Ministry of Health in Uganda has a integrated refugee response plan, and all the malaria interventions are actually aligned to that refugee response plan. So refugees are integrated in the policies, strategies, programs, and the different project activities. And we're going ahead to integrate systems, health information systems, into Ministry of Health, and all the systems are the building blocks for the World WHO. So again, together with the Ministry of Health, MSF, WHO, we developed a response framework for malaria response to new arrivals. This came as a realization of the new arrival influx from South Sudan. We received 1 million people in 3 months. So that brought the need for us to address the issue of malaria. And we'll get in new arrivals, put them in these bushes where there are no houses, so the risk of malaria was high. So we came up with the response framework to ensure that any new arrivals in future that comes into the country is managed in line with this framework. So just to let you know, since January up to today, we've got close to 30,000 people that have crossed the country, into the country. Last year, we received about 150,000. This is over and above the 1.5 million refugees that we have into the country. So part of the description in the response framework was to break down the phases when refugees come into the country. So broke down the phase of collection from the border, because as refugees cross the border, we tend to collect them. That's on day one when they collect. So we get register them, they are transported into a collection center, what we call the reception centers. By design, they're supposed to spend there 2 to 3 days, but from experience, they go up to 21 days. So at the collection centers, they live in dormitories, and there are vulnerabilities in those dormitory settings that we usually try to address and appreciate the vulnerabilities in those locations. Once they leave the dormitory-like setup, which is usually 15 kilometers from the border, we transport them further into the country where they are settled, which we call the settlements. And within the settlements, they're given small plots of land where they build their houses. But as you know, the first 3 months, they are yet to set up their houses. So they get the plastic sheetings, which they put on small sticks and use them as accommodation. So they're very small, and I'll show you the picture in a short while. So use of nets in those small tents is a challenge. So use of other malaria prevention methods become challenging. So that breakdown helps us to know what to do in which phase of the intervention. And then after 3 months, the refugees have settled, they've been able to construct their small houses that are usually comparable to the host population among whom they live. So within that response framework, we did define what package of interventions for malaria need to be provided at what phase of the displacement. So we looked at testing, treating, tracking, and protection in general. And as you can see in the third column, there's not little you can do at the border when they're crossing. But part of our health screening is ensuring that we test for malaria if someone has signs and symptoms. But also at the reception centers, it's more set up because of health facilities, ambulance, and health workers to manage the new arrivals. So again, we do all the test, treat, and track, but usually have challenges around protection because of the kind of infrastructure they are staying in and the congestion. One shelter can take up to 500 people, and hanging a net is a challenge. Spraying that plastic accommodation is a challenge. And those are some of the realities we deal with. So we try to realize the actual response when people have settled within the communities where they're living. I did highlight larviciding in red because it's a challenge we're facing, and that will come close to what I'll present at the end. I also did highlight red issue of chemoprophylaxis because it's one of the challenges that we're facing in the country. This is a slide of a reception center at close to the border when refugees are being moved from the border crossing to the transit centers. And that's a typical site. The vulnerability is largely the congestion. It's largely that people could have crossed the border with viral parasites, and maybe they're not symptomatic. So the idea there is more surveillance, ensuring that they get treatments when they fall sick, and they put in place mechanisms to pick those. So it's usually NETs, social behavior change communication, diagnosis and treatment, and surveillance. And in there, if one gets malaria, trust me, many people present with malaria to the health outpost that would have created in such a situation. So this slide looks at once they're in the settlement. I told you the first 3 months, the top picture gives you an idea of how they put up sticks and they put a plastic sheeting on top, and then they live in there. That house is shorter than a net. I had Pakistan complaining about the height of the net. Here, I think they need shorter nets than the ones that Pakistan is complaining about. But what's important here is that on average, the refugee household has 5 people. And all these 5 people are sleeping this one hut. And this is, even if you give 3 nets or you give 1.8 nets as per the standard, there's no space to hang all those nets. So you get all people sharing 1 net in this small structure. So then the effectiveness of sleeping a net for 5 people in 1 net becomes challenging. I'd like to interest you to the second picture below. That's when they have settled, and refugee lifespan is about 15 years. People will stay in this house for about 15 years. That house, as you can see, the maze is next to the house. It has no ventilation. That house has a cooking space, and somebody keeps goats and chicken as well. So nets can be hanged, but the bites outside are a lot more than what to be protected once they're in the nets at night. So there are lots of bites that takes place outside than what it is at night. And in this particular picture, actually, the village community worker actually had a positivity rate of 80%. Every time he went to households, more or less everybody had malaria. So respond with nets, behavior change communication, diagnosis and treatment, surveillance, and then case management, integrated case management by the community workers. So what we're seeing is that there is slightly higher incidence of malaria compared to the host population. So we track, like I said, our systems are integrated into the national systems. And what you're seeing that refugees tend to have a high incidence for malaria compared to their host within the same locality where they live. And that's the graph that speaks to that. That graph, if you look at it critically. But as the refugee operation, we track which sites have higher incidence than the other. And you can see the red spots on the map. And those correspond to locations that the Ministry of Health highlight as outbreak districts within the country. So one interesting, and Jimmy will speak to this, we managed to get indoor residual spraying last year in the northern part of the country. I think with support with Global Fund. We are seeing dividends, and you can see we're recording less cases than what they are in the channel graphs that were previously. So we think if we can scale up this, we can actually get a lot of reduction in terms of the malaria burden among refugees and maybe in other displaced populations anywhere in the world. So to speak to the theme of this conference, refugees are getting nets. Because as I said, they are integrated into the national systems, a national get the same refugee gets. It's a bit crowded, but I'd like to interest you to the last 4 bars. We do food security and nutrition surveys across the entire operation, but the last we did, 87% had actually slept in a net the day before. only 47% the nets were in a good condition. But just interesting that 86% had actually shared a net, and about 65%, two or more people had actually shared a net, about for 65%. So there is use of the net. Question is, why do we still have a high facilities coming people with malaria when the nets are being used and people are sleeping in the nets? So I think we need to think beyond the nets, especially in the humanitarian situations, to look at other tools that are available to ensure that we deliver a comprehensive package. But just to let you know, we're part of the national universal coverage campaign that's coming. So we try to innovate. We bought tablets, we gave VHD tablets to ensure they treat from their homes. They go house to house. A tablet shows them someone has fever, they treat, and that data comes straight to us. And that graph shows the number of VHDs and the people they are treating within the community on the tablet, and we get that data real time, and we can intervene in areas that show fairly high incidence of malaria. Yeah, I think from the short story I've given you during lunch, we need to agree, at least for the refugee and other displaced populations, nets alone can't give you the results you need, as we've demonstrated. So we need to look at mass drug administration, because the house I showed you in the middle of maize field, nets can only protect them from 8 to 6 when they sleep. For the rest of the day, they are getting bites. So we need to have MDA as part of the package to ensure that we reduce the parasite load within the community. 2, like I showed you the graphs in the north, IRS has demonstrated that you can actually reduce the incidence when you do spray. And then one thing we haven't tried is larviciding, and it's an area I think we don't have the resources and the comparative advantage to do it. It's something we'd like to try. One last point is generating information. We did present some of this, and someone said, yeah, Julius, yeah, we agree, your presentation is correct, but we don't believe you. So we need to generate strategic information that we can say, these are the drivers of malaria burden among refugees. What we shared is intuitively what we see, but we need to generate this strategic information. And I look at the partners in the room to be able to make this happen. Thank you so much for putting refugee on this agenda.
Thank you, Julius. Wonderful presentation. So next we'll have Dr. Emmanuel from Kenya Red Cross talk about the work that they're doing.
Thank you so much, Joe. Good afternoon, everyone. I'll give a brief presentation on what Kenya Red Cross is doing in terms of malaria control in the refugee setting, displaced population, as well as the last mile population. Kenya Red Cross is a UNHCR implementing health partner in the Kalobeyei refugee settlement, as well as Kakuma, as well as in the Dadaab refugee camp. So Kenya Red Cross, what is doing is that we are doing malaria. We are focused on malaria control programs, but we are not really focusing. We are not a partner with the Global Fund that is implementing malaria control efforts. So whatever we do is just try to support the partners that are implementing malaria control programs. So this is the outline of my presentation: malaria background in Kenya, KRCS support on vector control, refugee operations, IDPs, populations on the move, then challenges and gaps towards zero malaria transmission. So this is just a background of malaria. In Kenya, we classify malaria malaria epidemiological zones into 4. We have the endemic zone, that is the lake region and the coastal region, the epidemic area, the Western Highlands. Then we have the seasonal areas, that is arid and semi-arid areas, then the low-risk areas, the Central Highlands. In Kenya, over 70% of the population is at risk, with over 4 million infection rates per year. Then you see that due to the high infection rates, it's a high economic burden both the government and the households, which with a catastrophic cost for treatment, as well as in investment and prevention. So what is important to note in Kenya is that malaria epidemics can be predicted through meteorological information, local epidemiological data, and population dynamics. So this is just an overview. This is the ownership of mosquito nets in the country. See that from, from here, you can see that malaria infection and transmission mostly is the endemic, the lake region, where 63% of the population own nets. Then the highland regions, that is, this is epidemic area with 63% of ITN ownership. Then we have the coastal region, the high transmission endemic area with 50% ownership. Now, this is the seasonal area, arid and semi-arid area. And this has the population that has mosquito nets is about 18%. In the lower risk areas is about 19%. So Kenya Red Cross basically, it's a bit. So what we do, this is what we do. We do advocacy to increase investment in prevention and control of malaria. We respond to epidemics during surge, mostly in the Western Highlands, as well as the ASAL areas. Then we do humanitarian service provision to facilitate prevention and control of malaria among displaced population. Then provision of services, primary healthcare services for control of malaria in refugee settings, as well as humanitarian service points along the transit zones. Then strengthen county-specific social and behavior change communication, planning, and implementation during malaria epidemics. This is just to give you an overview of the distribution of the refugee population. This is Kakuma Kalobey refugee camp and settlement with a population of about 257,000. Then we have Dadaab refugee camp with a high population that is 240,000, but most of the population has not been registered. Then these refugees enter through these routes, the Western Flight Corridor. That is where we offer services, support asylum seekers and stranded refugees along this region to this point where we keep them before being moved to Kakuma refugee camp. So our interventions as a Kenya Red Cross in the Western Flight Corridor starts from this point, whereby they arrive at this point, that is the Kitale Transit Center. They are given mosquito nets per household. Then they stay here for about 2 weeks, and then they are moved to Kakuma refugee camp. But for Garissa, that is the Dadaab refugee camp, the infection rate is a bit low. So most cases are reported in the western region. And then in the Kakuma Kalobey setting, malaria is the third most common cause of morbidity and mortality, with a seasonal variation in infection rate that is high during the rain season and low during the dry season. So this is just an overview of the malaria infection rate at the Kalobey refugee settlement. You see that it starts peaking around May. Then in August, that is when the infection rate is very high, and drops in November. So this is a comparison of the data obtained in 2020, 2021, and 2022. Now, this is Kakuma refugee camp. We have an health implementing partner taking lead in health matters in this camp, but these are just the infection rates between 2020 and 2022. So you see that it's the same trend in around May, June. That is when the cases start peaking and then drop in November. So what we do in this refugee settlement, we offer treatment services to the population that present at those facilities. Then we also carry out surveillance as well as the distribution of mosquito nets. So we also offer health education and sensitizations to persons of concern. Then distribution of distribution of mosquito nets, mainly to pregnant women and children under 1 year. You see that one of the challenges that I've highlighted at the end is limited availability of nets, so we are not able to distribute to the whole population. The last time that we had a mass distribution of nets was in 2020, but we couldn't cover all the population. Then we also have community-based surveillance by community health volunteers for early detection and trigger measures when we have epidemics. Then we also use the climate information as a guide to controlling the epidemics. So something interesting that happened over the past 3 years, we've had an increasing infection rate. So, but initially this area is classified as ASAL, that is with seasonal transmission. But over the past 3 years, we've had like increased transmission. So this area was categorized as an epidemic area. So this led to the Ministry of Health rolling out insecticide-treated mosquito nets distribution in the entire county of Turkana to just cover women and children under 1 year. So the plans are to carry out mass periodic distribution for the population, as well as both the host and the refugee population. Then for populations on the move, these are the refugees along the Western Flight Corridor. These are received at the Kitale Transit Center. Then whenever they are received, they receive a mosquito nets as they await facilitation to Kakuma Refugee Camp and Kalobey Refugee Settlement. So they receive a net at this point, and we ensure that they sleep under a mosquito net, because this area, that is Kitale, is at the malaria epidemic zone. Then for displaced population, these ones are displaced mainly due to natural calamities like flooding and conflicts. So what we've done as Kenya Red Cross, we've included mosquito nets as part of the relief pack, which we distribute to the households. Then we also do vector control to the in the displacement camps. So what we do is spray those, we carry out spraying in the camps. Then for the populations, other populations, we also carry out integrated medical outreaches where we test, treat, as well as distribute mosquito nets. Then we also do risk communication and community engagement. Then for the hard to reach and last mile population, these are populations that have limited access to the basic services. You see that in some populations, they have facilities, but these facilities don't have staff. So what we do as Kenya Red Cross is that we organize integrated medical outreaches in those far areas that have facilities and there are no staffing, or there are no facilities at all. So in these areas, we carry out basic services. By integrated, I mean we take a team to that area, that is including clinical officers, nurses, doctors. They're able to screen, treat, and as well as distribute mosquito nets and treat at the same time. So Kenya Red Cross does bi-weekly medical outreaches, mostly in areas in Turkana County that the partners have been allocated. So like every 2 weeks, they go to different sites, distribute mosquito nets mainly to women and children, and then treat symptomatic cases. And then also we do risk communication and engagement, then refer and link to other facilities. Then these are the gaps that we are facing as Kenya Red Cross. One of them is inadequate supply of mosquito nets for mass distribution to the entire refugee settlement. So the last time that was distributed was in 2020, and it didn't reach the whole population. And one of the things that is contributing to this is the high influx. Like for now in Kakuma Kalobey refugee settlement, we have over 10,000 unregistered refugees. In the Dadaab refugee camp, we have over 120,000. So it becomes a bit difficult to plan and distribute mosquito nets to this population. Then something else that has prevented the efforts towards eradicating malaria or mosquito bites is outdoor mosquito bites that often witnessed in these areas. You see that the northern part of Kenya is very hot, so most people tend to spend most time outside. So we have more transmission taking place outside the houses than inside. Then another thing that has been a challenge is behavioral challenges. You see that we distribute these mosquito nets to the population, but what happens is that these people use the mosquito nets for other purposes. They will use it for like to fence vegetable gardens, of which it's not the intended purpose, and some are just hesitant to use them. So then for the population in these refugee camps, as well as where we respond to emergencies, we have limited control measures, only distributing mosquito nets, especially for the refugee camps and settlement and case management. But there's need for other services such as chemoprophylaxis, indoor spraying of houses, then stagnant water, and also working on the breeding areas. Thank you so much. This is just a photo showing what we do. This is a distribution of the relief pack with a mosquito net here to the affected population in Baringo, where they were displaced by bandit attacks. Then here, this is a medical outreach in one of the areas in Turkana County, whereby a pregnant woman is receiving a mosquito net as part of the interventions that we do in Turkana County. Thank you so much. That was my time. Have a blessed afternoon.
Thank you, Dr. Emmanuel. So our last presentation will be from Muhammad, also from Kenya Red Cross, talking about dignified digital identification.
Thank you. Good afternoon, colleagues. I'm Mohamed Baira Mohamed. I work with the Kenya Red Cross Society as an innovation officer. And I majorly mostly on blockchain and community-driven solutions. So our main mandate as innovation department with the Kenya Red Cross is we co-design, pilot, implement new humanitarian innovative approaches then we develop proof of concepts, then we scale them up. So today I'm going to present about the dignified digital identities. And we all can agree here, or majority of us can agree here, that lack of identification in a humanitarian crisis leads to adverse effects of vulnerability. And that's why the Kenya Red Cross Society with the partner national society, Uganda Red Cross, and through the support from the IFRC and the Digit Consortium, we are championing this particular solution, at least to provide a functional identity to the persons of concerns. So the outline of my presentation is I'll deal more on the problem statement, then I'll focus on the power of Digit. Then I'll also share some experience on the Digit use cases. These are the pilots and the actual implementations. Then I'll describe the process flow. Then we'll focus on the way forward and opportunities. So in the context of migration or displacement, persons of concern. So when I say persons of concerns, I mean the refugees and the displaced communities. So persons of concerns are so vulnerable because they lack some eligibility in accessing some humanitarian aid. We may find out in some of our cash interventions that one has to have a form of identity for you to be integrated in that particular intervention. So if a person of concern doesn't have any form of identity, he or she may end up not being part of that particular intervention. Then on the other angle, if we have persons of concerns that are eligible to be part of a cash intervention. Wow. a form of a national identification. Then we also had some pilot in conjunction with the Save the Children Kenya, who piloted it in the Dadaab refugee settings. Then Digit in health context, we piloted it in Turkana, Kalobe and the Kakuma camp. We have a health facility in Turkana. So we were able to meet with persons of concerns in Turkana, and we created digital wallets for them that had minimum health data for them to access the continuity of healthcare. So the process flow of this particular Digit solution is when a person of concern comes to a health facility, the clinical officer who has been trained in this particular technology collects data, but it should be bare minimum data. It's like the about data, maybe name, age, the gender, then the health data. So this particular solution is able to be integrated with other health management systems in the health centers. So then after the data collection, the digital wallets are created and credentials are issued. So this person of concern would be issued with a QR code that is encrypted, and one cannot decrypt the information that is part of the QR code with the human eye. Then verification using QR codes to establish eligibility. So once they've received the QR codes, they can now go on with their normal procedures in that health facility. In their next visit in the health facility, they just have to come with the QR code, then the clinical officer could just verify and could access the information. But one thing that we need to note is the person of concern has the power to give out the consent for the clinical officer or any humanitarian aid organization that is part of this particular system to access the data. So the way forward or opportunities that we have this particular solution is the integration of Digit. So during the cash interventions pilots, we were able to integrate this solution with the Red Rose system. So the Red Rose system was more of a data management system than the interface of the Digit solution was used to create the digital wallets and provide credentials. Then for the Digit in health context, we are working with hospital management systems in Turkana to see how the Digit system could be integrated with the hospital management systems. Then when we talk about the data protection for beneficiaries, we've been having data protection impact assessments to see which areas we could strengthen when it comes to data protection. Then advocacy and interoperability, we've had advocacy sessions with the Ministry of Health, Ministry of Interior and Coordination, who have been mandated to register the populations here with the government and also with UNHCR and other stakeholders that are part of the refugee camp settings. Then we have a system called Rapid Pro, which is used for mobilization and information sharing. So the information about Digit, or maybe if there's any next visits in the health centers, a Rapid Pro system is used to disseminate that particular information in form of SMS. Then we've been having digital literacy trainings that are tailored for the staff or even other humanitarian organizations that are interested to be part of this particular Digit consortium. So that's come towards the end of my presentation. And in case if we could see these areas that we could align, especially with our interventions, especially on how to provide the functional identities to the person of concerns that we are dealing with in our respective areas. So feel free to reach out and we see how we could extend these conversations. Thank you, and sorry for the technical challenges.
Thank you, Mohammed. So we have just a few minutes. We can open it up for questions for either myself and Jess on AMP and emergent issues, and the new working group that Jason mentioned. Julius, Uganda, or Emmanuel and Mohammed from Kenya. Any questions? Oh, we've got a question in the back.
Crispin, I'm coming. Can I ask one question as a co-chair? For Julius, please. I'm curious about the cost of the long-lasting insecticide treated tents. And I'm also curious about your funding gaps. Thanks.
Okay, thank you very much. My question goes to Emmanuel. First of all, I want to say thanks for the beautiful presentation. You outlined in the presentation some of the challenges regarding the misuse of nets. Well, what I did not see was what measures were put into place, what SPCC measure was put into place to address misuse. Thank you.
We want to take one more, maybe? I
Yep.
think I saw a couple hands up.
There's
over there.
Medard.
So, good afternoon, everyone, once again. My name is Sulaiman Abarona, CRS. My question goes to Mohammed. I want to ask about the solution. How do you integrate your solution with other partners, the other humanitarian partners? And apart from that, the issues of QR code and a PIN, what's the main purpose of the PIN for that? Is it for the viewer or for the beneficiary? Thank you.
Maybe we'll just take
One
Medard's
more.
question and then we'll go from there.
Mine is on distribution gap, especially for Kenya, where you targeted to cover in the account and you missed some population. Don't you need to review your quantification parameters so that you use it as part of the lessons for the next programming? If we are asked to do another mass campaign, will you go to the same, will you get the same problems, or you are running for improvement? Thank you.
So to Emmanuel, Mohammed rather, thank you very much for the presentation. So my question is on the possibility of some of these persons of concerns not being able to present their QR code when they want to have access to healthcare. What happens if they lose their QR code?
Great, thank you. I think we'll take those questions there and we'll see. So maybe we'll start with Manuel.
Thanks. I just have one question regarding what to answer. It's about the tents. When we're conceptualizing the response framework, I thought the tents existed, but I must say we've never bought any, partly because even the refugee management in Uganda, it was very expensive to use tents as accommodations for the population that are receiving. So what you're doing is gradually doing dormitory setup because it's cheaper to manage the large population that keeps coming in. So we never attempted, but we had a thinking in that at a technical level. Over.
Thank you for the questions. So the first question about integrating this solution with other partners. So we've had some interoperability simulations with some partners in Turkana, like the International Rescue Committee. We have Kakuma Mission Hospital. So in these particular simulations, we were trying to see what would be the challenges or the opportunities, how these other health-based organizations in Kalobey or Turkana that we could achieve with this particular solution. So in terms of the integration, like when we issue QR codes or to the person of concern, and if maybe our health facility is in Kalobey, and if there is some migration or displacement maybe from Kalobey, if this particular person of concern has been repatriated to his or her original countries, of which we have national societies in those particular original countries, and let's give an example. He or she has been repatriated maybe to DRC Congo, and we have DRC Red Cross in Congo that has a health institute, which is part of this particular system. So the person of concern would just use the same QR code in DRC, and the clinical officer in DRC would be able to access the health data or information for this particular person of concern. So even if this person of concern has lost his or her health records, he will be in a position to have this. Then the main use of the PIN, so the main use of the PIN is for data protection, and this particular PIN, as a humanitarian aid organization or as the guardian, the Kenya Red Cross, the guardian of the system, we are not able to see or view the pins that the person of concern have. So they are able to issue these pins when they visit the health facility for the clinical officer now to access the health records. Then also when it comes to interoperability, where maybe a certain organization that is part of this system may request information or data from another organization of a particular person of concern or beneficiary. So the organization A won't be able to send data without the consent of the person of concern. So the person of concern would receive an SMS like, hey, Mohammed, so organization A wants to send your health data or identity data to organization B. Do you agree or not? So if maybe for you to agree, you have to input number 1. For you to disagree, you input number 2. So the person of concern would input number 1 for agreeing, or would input number 2 for disagreeing. And even he or she is in a position to like question what's the purpose of this data that is being requested. Then when it comes to person of concerns losing the QR codes, yes, so the clinical officer is in a position to print out new QR codes, then laminate and issue out to this particular person of concerns. Thank you.
Okay, thank you so much. I will respond to 2 questions. One of them was regarding the behavior challenges at the refugee settlement and the camp. So far, there is continuous use of nets for other purposes, but the measures that we put in place is 1, we carry out mass sensitization. We use the local radio stations to just sensitize the population. As I had indicated that this area was classified as a seasonal malaria transmission zone, but now it has moved to epidemic. So we've increased our effort towards ensuring that we reduce transmission, and the people use the nets for protection against malaria, mosquito bites, rather than for protecting their gardens. Then secondly, we also engage community health volunteers and community leaders through community dialogues and action days to just ensure that they get the information and they're able to utilize the nets for the planned purpose. And then maybe something else on this, another question that was asked was regarding the mass campaigns. As I had already indicated, we are not implementing a malaria program in Kalubei and Kakuma refugee camps, but the malaria mosquito nets that we distribute are mainly donations and supply from UNHCR. But whatever we receive is highly dependent on the influx of refugees and asylum seekers. So sometimes you see that, like this year, we've received so many asylum seekers. So that means that sometimes you find that most resources are allocated towards catering for the needs of the refugees and asylum seekers. And to get nets to just carry out mass campaigns is a bit challenging. So the nets that we supply there, we distribute are mainly from MOH. Since January, the area was classified as a malaria epidemic zone. So far, like from January up to now, we've received about 5,000 mosquito nets, which is still very low. So mostly we are focusing on distributing to pregnant and lactating women. But this is a gap that still needs planning with partners and interested donors to just ensure that we have adequate coverage in the refugee population. Thank you.
Thank you again to Julius, Mohammed, and Emmanuel for presenting today. Thank you all for spending your lunch with us. To reemphasize Jason's point from before, there will be a new working group starting with an AMP focused on displaced populations, IDPs, refugees. So those who are interested in joining, who are interested in helping co-chair, please come find Jess and I at some point. And then thank you again for your attention, and another round of applause for our 3 presenters. Thank you. By turning it over to.
Good. I would like to invite our next moderator for the last session of our partners meeting. So Asha Muhammad Ali, who works with UNDP in Chad, and she'll be leading this next session on improving planning, measurement outcomes, and availability of data for decision making, the second part of the discussion. So welcome, Asha.
Thank you. On va poursuivre avec le français, donc je vais modérer en français. Merci beaucoup. Je m'appelle Aïcha Mohamed Ali. Je voudrais remercier l'AMP qui m'a donné cette opportunité de modérer cette session et merci spécialement à Marcy. Donc, nous allons poursuivre la session sur améliorer la planification, la mesure, les résultats et la disponibilité des données pour la prise de décision. Donc, cette session sera constituée de plusieurs panélistes. Donc, permettez-moi de les accueillir. Il s'agit de l'équipe du Nigeria, composée de Marie Essema, Fatima Ali et Fiani Oudeye. L'équipe du Nigeria. Merci de prendre place. Je vais ensuite appeler l'équipe du Sénégal. Je ne sais pas s'ils sont dans la salle. Ensuite, nous aurons une présentation en ligne. Et puis, Christian de CRS. Vous pouvez prendre place, s'il vous plaît. Merci d'applaudir nos panélistes, s'il vous plaît. L'équipe du Sénégal va nous rejoindre dès qu'ils seront là. Donc, on va commencer avec la première présentation qui porte sur améliorer les monitorages post-distribution, l'analyse des données et l'utilisation des données pour la prise de décision après la distribution de la campagne de MILDA au Nigeria. Donc, merci d'accueillir Marie Essema.
Thank you, everybody. Please, can I have the slides come on? Okay, I'm going to talk on improving end process monitoring, data analysis, and use of decision-making post ITN campaigns in Nigeria. So I'm going to talk about, first of all, I'm going to introduce, then we are going to talk about the previous ITN campaign end process methodology, the challenges with the previous methodology, the benefits of the current methodology, implementation of the current methodology, the CLQS, classification of corrective action planning. Then we talk on the data analysis and presentation, then challenges and recommendation. So on this, I'll start with introducing this by telling you that Nigeria actually has ITN nets as its major vector control strategy for malaria control in Nigeria. Then I will talk on we have had several rounds of campaigns conducted since 2009. And with these, we have shared over 250 million ITN so far. And also, we have done the assessment of the process, the output and outcome, key to improving effectiveness of the strategy. So I'll start by defining what we mean by the end process. So end process actually is a rapid assessment usually conducted at the end of ITN distribution campaigns in Nigeria. And we are giving reasons why we do this because of the unbiased evaluation of the ITN distribution, output, and immediate outcomes. And this is how we measure it. We measure through the key outputs, outcome indicators of ITN distribution process. Example, the ITN coverage, ownership, access, hanging rate, etc. Independent, and this is usually conducted by the independent monitors called campaign monitoring teams, the CMT. And this particular presentation, we're going to be 3. I'll handle the whole session, what we had been doing before, and I'll also hand over to my colleague to continue what we're doing now, the data analysis, and my other colleague will come on to talk about the recommendations and the challenges. So this is actually a 4-word selected from each LGA. I like to explain that in Nigeria, we have the national level, the state level, we have the local government area level, we have the ward level, and we also have the settlements and communities. So to make it easy for us, we have this 4x4x10 methodology, which 4 words are selected from each local government area, what we call LGA, in the campaign state. We usually choose 2 urban and 2 rural. Then we have the 4 settlements, that's the 4 communities per selected ward. And we have 10 households systematically sampled for interview per settlement, per selected settlement. And each campaign monitoring team is assigned to a ward and samples 40 households in total. Data collection is done electronically using the tool on ODK application. So the challenges for this particular methodology has to do that this sampling process was very unscientific. So we had to improve on it. And this particular sampling, it didn't have enough statistical power for conclusions. It couldn't lead us to any good decision making. And also we had, since it was done on Excel-based summary template, it couldn't give us enough analysis, and the classification criteria for corrective action was non-existent. So I'll call on my next colleague to follow up on this. Thank you.
Good afternoon, everyone. My name is Ifeanyi Udoi, and I work with Society for Family Health, and called SFH for short. And is one of the implementing partners for the Global Fund Malaria Project in Nigeria, and one of the SRs supporting the implementation of the Global Fund grants in Nigeria. So I'll carry on from where my colleagues stopped by giving us information about the new methodology that we were able to come up with support from AMP. to conduct the end process for the campaigns that we do in Nigeria. So I'm sure some of us will be worried about the mention of Excel not being good for analysis, well, because we know Excel is a powerful tool for doing a lot of analysis. But the tool that we were using previously was actually a template designed such that the summary data from the primary data that were collected from the field are imputed into the templates, and it basically gives proportions and all that. So we are unable to see some fine details from the data collected from the field. So with the assistance from AMP, we were able to move on to adopt a new methodology, which some of us back in Nigeria rather prefer to call 8-10 strategy. You know, the one we had before called 4-4-10, but the new strategy, even though it's not mentioned in the slide, but some of us call it the 8-10 strategy. And that's because it aims to select 8 clusters from all the LGAs within the states where the campaign has been conducted. And within these 8, in each of these 8 clusters, 10 households are systematically selected and interviewed, and the data from the process are collected from these households. So, but this method is actually based on cluster lot quality assessment sampling methodology. And that's basically because, the primary sampling unit for this new methodology starts from the ward level, because that's the level where we have a reliable data that is near accurate in terms of the listing and the population of the administrative units, the lowest administrative units that will sample from, which is the ward. So it's based on the cluster lot quality sampling methodology, which is also cost effective for us. And the 8 clusters are selected using probability proportional to size PPS methodology. So later we'll show the steps of how the process is done. And 8 clusters, like I mentioned, are selected from each of the LGAs. And then after the selection of the clusters, we go further to do the WHO method of segmentation to narrow down to, excuse me, the cluster where the households are selected. And what we do is to divide, so the cluster selected, the cluster selection actually helps us to identify a ward where these clusters will be selected. So within the ward, after the ward has been selected, the segmentation process starts. And what happens basically is the ward selected is divided into 4 quadrants, and 1 quadrant is randomly selected. You narrow down into that quadrant until we're able to get a quadrant where you find about 20 households from where the households are systematically selected. So, but ideally, this process is done using a map. But in Nigeria, we don't have, the map we have will not be able to help us to do this process, because even if we have the map that is very good, at the scale of the map may not be able to allow you to see the details of the households within those, the map you have. So we're able to look or explore Google Map for this process, and it has been very helpful. So we use the Google Map to do the segmentation the same way, following the same principles based on that WHO method. And then at the end, by the time we identify a cluster, we 10 households are now selected from that cluster systematically, which will also show in the coming slides. Okay, so but then the data from this, unlike the past where we use Excel templates to do the analysis, we now use Stata. And because PPS is used for the cluster selection, the data, they are all weighted before the analysis. Okay, so this is trying to illustrate the steps that we take in doing the cluster selection. So first, we have the words. So this is an example from what we've done in the past. So here we have, excuse me, this is the list of words from the states. This was from a state we call Niger in Nigeria, Niger State in Nigeria. So from one of the LGAs, the LGAs has this as the words. And what we do first is to arrange the population, the words in their order of increasing population. So the one at the top has the least population, while the one at the bottom has the highest. And on this column, we have the cumulative population. So at the end of the day, you can see that the total population we have here is what we have as cumulative population here. So this is the first step. So the second step is to calculate the PPS interval by dividing the cumulative population we have with the number of clusters we want to select. So that's that way we got the PPS interval here. And that also, okay, the next step is to identify the starting points. The starting points, so sorry, this is blocking it. I don't know how to get it off. So, but what we have here is the starting point, which is a random number picked between 1 and the sample interval we have here. So, and that number automatically becomes the first cluster. So wherever that number falls on this cumulative population gets selected. So we have 12,045 here, which is why, because it's falling in between 14,000. So it's picked as a cluster 1. So the next cluster is selected by adding the sampling interval to the random number that was selected earlier. So which gave 36,257, and that falls in between this and this. So that's cluster 2. So we continue the process to select the 8 clusters. So by the time we are done with this, we go to the Google map, which I will show in the next slide. I'll show the steps in the next slide. So on the Google map, we're able to get the boundaries of these clusters, of these words. So the Google map is able to give us the boundaries of these words that we selected here. So where we now do the segmentation to get the final place, which is represented by this Google link. So because the data collectors will now use this Google link to go to the actual the point that was selected to do the listing of the households. So this also is used to develop what we call the roster that is issued to the state team, where because the clusters has already been selected in this, so we will leave a space for them to put in the names of the people that they are going to assign to do this data collection. So that way it makes the process faster. Okay, so the sample roster for the same person is developed from the clustering process. So if we now go to the next stage, this is the illustration of the segmentation process, where we first, the same way, so on Google Map, we have this representing this here. So this is divided mentally, because on a Google Map, we just follow these steps. We'll divide these boundaries into 4 segments, into 4 quadrants, randomly pick one of the quadrants, zoom down into it until we're able to see is a quadrant that has about 15 to 20 households, which is now picked as the cluster, and the Google Map is taken. the Google Map link is taken and put on that template. So for the household listing, so when the 15 to 20 households are identified, if it's in the urban area, the data collector is expected to use any of the randomization methods to pick the first household to visit. But if it's in urban area, we jump one house, go to the next. So you can see here, this is the first house sampled, the second one, the third one. But if it's in a rural area, we jump 2 households. So to do the process. All right, so the next step, okay, this is just to show the steps in doing the segmentation. So first on Google Map, at the top right, top left corner on the map, we type in the name of the ward and it gives us this boundary. So this is an example of what has been done in the past. So with this ward boundary, we do the segmentation to narrow down to, sorry, it's still showing the whole picture because in our illustration, but in real practice, we actually zoom down to the point where we do the selection. So here we'll pick this. So this was the final place that was from the segmentation process. We arrived at this place, and then to pick the Google Map link. Once you click on that, it generates, this pops up, and we click on the share icon here, which generates the Google Map link, which we copy and put into that template. So this is the step we follow to do that. Then, so the benefits of this method is one, it's compared to the last or what we've been doing in the past, it's pretty more scientific. And then because the analysis is also done with weighted, the samples are, the data collected from the processes weighted and then analyzed using data. We're able to have a narrower confidence interval when we do the analysis at the state level. So meaning that the data we get are more reliable. And then we also established classification criteria for corrective actions. And like I mentioned earlier, the data is performed with data and they are weighted. So with also support from AMP, we're able to get a do file that we use for the analysis. And then the other thing is, it also did not affect the number of CMTs that we engage for the process. It's still the same number we used in the past that we continue using. So the classification criteria that we adopted, and thanks to the team from Senegal, we actually borrowed this from your protocol. I want to acknowledge that. Okay, so here we agreed to have 3 levels of classification. One is from 100 to 90%. Then those are classified as pass. And for those ones, no actions are required because they are perceived to be doing very well for different indicators. So this is applied to the different indicators, which could be the ITN coverage, hanging rates, use, and so many others. But there are 5 key indicators that we actually analyze. So the next is between 80 to 90%. So those are well considered to be doing fairly well. So we would have loved everyone to be doing above 90%. So, but for this, we will now look into doing further investigations to find out where they may not be doing so well and what can be done to improve it. Then the other one is, the lowest one is below 80%, which are considered as fail. And we need to investigate further and consider supporting interventions if required to get them up to do better. Then, so this is a sample of the final analysis that is done, where we apply the classification rules. So we can see the indicators have been analyzed here. We have the ITN coverage here. So actually for the coverage, we are looking at households that were able to receive ITNs from the campaign process. So that's what we're considered here. Then here we look at amongst these households, how many of them got the correct number of nets that you're supposed to receive. And then here we look at the population access. Here we use as the use total, and here we look at the use amongst children under 5. So we can see that everyone is doing very well in terms of this, except for one LGA, which is not doing so badly. But then it's not, compared to others, they are not doing well. Then for the correct use, we now have most of them doing below the lowest classification. And for access, we have a few of them doing above or doing what we expect the maximum. And then we have the use total also not doing so well and all that. So this is just an example from one of the campaigns that have been done in the past. Then these are also converted into, because at the end of the campaigns, we usually do a debrief to the state team. So this is a sample of what we presented earlier, presented graphically, that is presented to the state team during the debriefing process to let them understand how the assessment of the campaign in terms of the different various indicators that were considered. So then this is the weighted data for all the campaigns that were done in 2022. In Nigeria, about 7 campaigns, I hope I'm right, yes, 7 campaigns were done in 2022. So we looked at, so we picked one of the indicators, which is correct use or correct number of ITNs issued to the households. So we could see that the confidence interval, range is pretty narrow, meaning that we can reliably, if every other issue, every other data quality issues are seen to be okay, we can reliably say that this is actual point data for this indicator. So this is the same indicator, but we are looking into more details now because it's kind of surprising. So in most of these states, the coverage were above 95%. But then we are seeing that the number of households actually got the right number of nets required is not as good as the coverage, because we are seeing for Delta State 60, and we have another one having a 57. So, but we see that some are getting more, some are getting less. So these are concerns that we also want to look into to see how can we improve them in the future. Then we also looked at some secondary indicators. So, but maybe here to save our time, we can just focus on these last ones, the percentage use of the ITNs. We could see that for all population, so we looked at it all ages, children under 5, and then pregnant women. So, but what is also kind of strange with this data is when we compare it with the data from you could see the use percentage ranging from 65 to 91% for under 5 years. For pregnant women, it's ranging from 73 to 92%. Where we compare it with the data from the last MIS that was done in 2021, or reported in 2021, we could see for pregnant women, about 50%, and for children under 5, about 41%. So it's raising some questions. Seems the use seems to be pretty high immediately after the campaigns, but then after some time it decreases. So what are the reasons for that? So at this point, I will call on my colleague Fatima to come and take us further into the other, where we're looking at the challenges or the reasons for these challenges and a way forward, our recommendations. Thank you very much.
Hi, thank you very much, Ifeanyi. So I'll continue from here. So basically, after the end process, what do we do? He has mentioned that we present the findings to the state. So after every campaign implementation, we debrief the state and let them know how well the campaign went and what are the gaps that have been identified. We also make recommendations on what areas they can improve on. And then we also get lessons learned, which will feed into the lessons learned meeting at the end of the state. And such data are also valuable when we do national strategy review. So we take into consideration whatever findings, whatever gaps that have been identified across states in Nigeria, and then feed into the national strategy. So you agree that this strategy allows for more in-depth analysis, and it raises a lot of questions that we need to investigate further. And then at the outcome level, we need to understand better, as he has outlined, that why is it that during distribution, the nets are received by the households and retained, but some of them, when you go for the end process, they are not found in the household. So where did they go? And then why is it that ITN ownership hanging rates are relatively high just after campaign, and then a few months later, it drops drastically. So I think that's a really curious thing to investigate. Then in terms of process, why were certain households missed? And what can we do to avoid them in the future? Why did certain households receive incorrect number of nets? And what can we do to, correct that? And then most importantly, these observations, are they real or biased due to some steps in the evaluation process? And then in terms of operations, do we now review the lowest range? So I'm talking about the red areas that he presented earlier. What do we need to investigate further? So those are lessons learned, but we have some challenges. Number one being political interference in recruiting the CMTs themselves. So that means you may get people that lack the capacity or don't have the technical ability to avoid introducing some bias in their findings. And then there's a capacity gap because, as you can see, using Stata and this high level of investigation or strategy, you need someone that people with good background in data analysis. And then this new methodology, mostly by the lay people, they think is quite tedious. So you need to have someone with the background and passion for it to follow it all the way through. And then, of course, the Stata application itself, not everybody has access to it. And then the other challenge in the process is when you finish doing the clustering, it's randomly selected. So it may fall in an area that has security challenges. And in Nigeria, we have a couple of our states or local government within states that have security challenges, which means it's not that easy to send CMTs to such areas. So what do? You see that distorts the process of selection. And then when you have hard to reach area, all campaigns depend on budget, and there's a limit to how much you can pay for transportation. And if it's a hard to reach area, that automatically translates to more money. That means multiple transportation before you get there. So we do get some challenges on how to overcome the extra cost that might be required. So recommendation for the political interference, just high level advocacy as much as possible, to stress to them the importance of getting the right people to do this work. And then it's key to identify a model that stimulates state and LGA level personnel interests. So maybe some kind of reward system to encourage them to use this strategy in their future activities. And we need to have more formal training. More people should be trained at the national level, implementing partners and even the state. And then the subscription to the starter application itself. And then to strengthen our in-process monitoring so that as the findings reveal where the gaps are, we can focus more during end process to even avoid having such situations. And of course, I mentioned the limitation of hard to reach areas. So special budgetary considerations need to be done to accommodate such areas. So that's the end of our presentation. We just want to acknowledge our following partners, especially AMP and MAC, for supporting us with technically to do this process. Thank you very much.
Merci. Merci beaucoup à l'équipe du Nigeria pour cette excellente présentation qui nous rappelle l'importance du suivi post-distribution et surtout l'utilisation de ces données. Donc, je vais inviter le présentateur suivant, le profil du Sénégal sur la digitalisation des interventions de lutte contre le paludisme.
Merci. Bonsoir à tout le monde. Je pense que je vais donner l'opportunité à certains d'entre nous d'utiliser enfin les écouteurs, hein, parce que je vais présenter en français. Voilà, nous allons donc, je m'appelle Laksouk Nilan Diouf, je travaille au programme national de lutte contre le paludisme du Sénégal. Nous allons partager avec vous cette présentation qui porte un peu sur le système de collecte que nous utilisons chez nous et nous allons échanger également sur le profil de digitalisation, n'est-ce pas, des données du paludisme. Le plan que nous vous proposons est le suivant. Donc, nous allons revenir sur les sources de données du paludisme, échanger sur le circuit de l'information, vous présenter le profil de digitalisation et enfin terminer par les perspectives en matière de digitalisation. Il faut d'emblée dire que chez nous, nous avons plusieurs sources donc, qui alimentent le système global. Alors, le système global est là. Donc, c'est le système de suivi et évaluation du paludisme, autour duquel gravitent plusieurs autres sources qui alimentent en termes d'information la source principale. Il s'agit principalement donc, disons, des sources internes. La première, c'est le système d'information sanitaire de routine et à tous les niveaux. Et je dois préciser qu'au niveau national, nous avons des sources internes qui sont étagées. Nous commençons par le niveau communautaire. Ensuite, nous avons le niveau opérationnel, nous avons le niveau intermédiaire et le niveau central. Donc, une des premières sources, c'est le système d'information sanitaire de routine. Nous avons également ce qu'on appelle chez nous les sources qui sont relatives à la surveillance sentinelle. Nous avons au niveau national 24 sites sentinelles. Et ces 24 sites sentinelles-là alimentent en termes d'information le système global. Nous avons au niveau national 14 régions médicales. Et au niveau de 9 régions, nous avons des sites sentinelles, donc, qui sont des pourvoyeurs d'informations. Nous avons également, disons, le système événementiel, parce que de façon régulière, nous organisons des campagnes de chimioprévention du paludisme saisonnier, SMC. Nous organisons également des campagnes de distribution de masse de moustiquaires, etc. Donc, toutes ces informations également viennent alimenter le système global. À côté de ces sources d'information, nous avons d'autres sources qui sont relatives aux enquêtes qui sont régulièrement menées au niveau national. Nous avons les recherches opérationnelles qui sont menées par les instituts, les universités et les centres de formation. Nous avons les enquêtes nationales auprès des ménages également qui sont régulièrement menées au niveau national. Nous avons également un centre des opérations d'urgence sanitaire, donc qui en termes d'information également met à la disposition du programme des informations cruciales. D'autres sources d'information, c'est la surveillance entomologique qui est effectuée par l'Université Cheikh Anta Diop de Dakar. Il y a également la surveillance parasitologique qui est aussi proposée par l'Université de Dakar. Enfin, les dernières sources qui alimentent le système. C'est les données météorologiques avec l'Agence nationale qui s'occupe de tous ces aspects-là. Il y a également le système d'information géographique et enfin, le système de surveillance démographique et de santé. Alors, à côté de ce système et de ces sources de données, nous avons le DHS2 national. Et je dois préciser que depuis 2020, toutes les données du paludisme sont versées dans le DHS2 national. Et tous les centres de responsabilité attaquent directement la plateforme et mettent à la disposition donc de cette plateforme les données relatives à la lutte contre le paludisme. Et comme vous le voyez ici, nous avons donc au niveau le plus périphérique le niveau communautaire avec les sites PECADOM, les cases de santé et tous les autres sites communautaires. À un autre niveau, nous avons les centres, les postes de santé et les EPS. Et le niveau communautaire fait une transmission de données vers le niveau opérationnel. Et il y a naturellement une rétro-information donc, qui se fait du niveau opérationnel donc, vers le niveau communautaire. Après ce niveau, nous avons le niveau du district sanitaire. Là aussi, il y a une transmission de données et une transmission et une rétro-information donc, qui est opérée. Et ces deux niveaux-là, les niveaux centre et poste de santé, le niveau district sanitaire, attaquent directement le DHS2, donc en termes de renseignement. Nous avons le niveau intermédiaire, donc avec les régions médicales, et enfin, le niveau central. On n'oublie pas les établissements publics de santé, les hôpitaux, qui sont au nombre de 40 au niveau national, qui renseignent directement le DHS2 en donc, termes d'informations relatives aux activités de lutte contre le paludisme. Alors, comment est organisée notre collecte au niveau national? Les modalités de cette collecte donc, sont les suivantes. La première modalité, c'est la formation des acteurs. C'est tout ce qui est procédure de suivi et évaluation. Donc, tous les acteurs, à tous les niveaux qu'ils se trouvent, ils sont formés en procédure de suivi et évaluation. Du point de vue de la collecte, du point de vue de la transmission, à tous les niveaux, postes de santé, centres de santé, hôpitaux et niveau communautaire. La seconde modalité, c'est la mise en place d'outils de collecte et de synthèse hebdomadaire et mensuelle des données. Donc, le rapportage se fait au niveau, à la période donc, hebdomadaire et mensuelle. Nous avons comme troisième modalité le paramétrage dans le DHS2 des formulaires de rapport paludisme. Donc, il y a plusieurs formulaires paludisme qui sont donc contenus dans le DHS2 qui nous permettent donc de collecter l'information donc au niveau des centres de santé, des postes de santé et des hôpitaux. Nous avons comme quatrième modalité la saisie proprement dite dans le DHS2 par les responsables donc des formations sanitaires. Cette saisie se fait avant le 15 de chaque mois et la validation qui va suivre donc se fait le 15 également de chaque mois, ce qui nous permet de disposer à temps des données et avoir une bonne complétude du point de vue donc des données. Alors, nous procédons également à ce qu'on appelle un contrôle de cohérence et de qualité des données. Et ce contrôle de cohérence et de qualité se fait par le biais donc du paramétrage dans le DHS2 d'un rapport standard. Autrement dit, dans le DHS2, nous avons un rapport standard qui nous renseigne sur les indicateurs majeurs de la lutte contre le paludisme. Donc, tous les centres de responsabilité donc, peuvent disposer donc, de ce rapport standard sur les indicateurs de morbimortalité qui sont liés au paludisme. Il y a une activité fondamentale chez nous, c'est l'organisation des réunions trimestrielles. Donc, c'est les revues que nous organisons tous les trimestres, à la fin de chaque trimestre, avec tous les districts sanitaires. Je rappelle qu'au Sénégal, nous avons 79 districts sanitaires, nous avons 40 hôpitaux et nous organisons pour tous ces centres de responsabilité des revues trimestrielles. Et lors de ces revues, on a véritablement comme objectif d'exploiter les rapports standards des districts et des hôpitaux, d'identifier toutes les incohérences et de faire des analyses de tendance, de voir un peu quelle est la physionomie au moment où nous sommes et la physionomie du paludisme dans notre pays. Et enfin, donc, nous formulons à travers ces activités des recommandations qui vont nous permettre un peu d'améliorer la qualité des données. Enfin, toujours dans ce chapitre contrôle, nous organisons des supervisions semestrielles à tous les niveaux. Donc, au niveau des établissements publics de santé et au niveau des districts sanitaires, des centres de santé et postes de santé. Et cette activité de supervision qui est menée tous les semestres nous permet d'évaluer la qualité de la prise en charge. Parce qu'effectivement, on s'est rendu compte qu'il y avait des lacunes dans la prise en charge. Et ces supervisions, donc, sont les moments idéaux véritablement pour nous permettre un peu de rectifier le tir et un peu de changer également les choses. Il y a aussi naturellement, comme dernière rubrique dans cette supervision, la vérification des données sur site que nous menons de façon également assez régulière. Alors, tout cela nous permet de diffuser 2 documents. Le premier document, c'est le bulletin épidémiologique, le bulletin de surveillance, excusez-moi, Sentinelle. Il est diffusé toutes les semaines. Donc, tous les mardis, ce bulletin donc, nous renseigne sur l'épidémiologie du paludisme, donc au niveau des 24 sites Sentinelle que j'ai précédemment annoncé. Le deuxième document que nous publions chaque année, c'est le bulletin épidémiologique annuel. Là aussi, nous avons toutes les informations relatives aux activités de lutte contre le paludisme, donc pendant l'année écoulée. Alors, ces bulletins épidémiologiques, les données utilisées par ces bulletins, donc c'est les données de routine. Comme je l'ai dit tantôt, ces données sont extraites du DHS2. Alors, c'est les données de morbimortalité, c'est toutes les autres données de prestations, donc comme les CPN, la distribution de routine de moustiquaires, etc. Il y a également comme autres données utilisées les enquêtes démographiques et de santé que nous menons au niveau donc, national. Et ces EDS nous renseignent sur la prévalence parasitaire, par exemple. Ces EDS également nous donnent des informations assez précises et importantes sur les indicateurs de survie au niveau national. Toujours par rapport à ces données utilisées, il y a les données des interventions, donc que nous faisons de façon périodique. C'est les campagnes de chibioprévention du paludisme saisonnier qui sont menées au niveau de 16 districts sanitaires et dans 5 régions du pays. C'est les campagnes AID qui sont menées au niveau de 8 districts sanitaires. Et enfin, les campagnes de couverture universelle en MILDA. Et je dois préciser ici que par rapport à ces campagnes de couverture universelle en MILDA, tous les postes de santé, qui sont plus d'1 million au Sénégal, renseignent directement le DHS2 web. Donc, autrement dit, et c'est ce que nous avons essayé de symboliser ici. Ici, nous sommes au centre de santé de Saint-Louis, par exemple, qui attaque directement la base DHS2 pour mettre à la disposition donc, de tous les intervenants les informations donc précises par rapport à la campagne CIU-MILDA. Alors, donc tout cela nous permet de mettre à jour la cartographie de nos stratégies et de toutes les interventions de lutte contre le paludisme. C'est donc dire que c'est assez fondamental cette gestion que nous faisons par rapport à toutes les données relatives au paludisme et ce qui nous permet de dire que le cycle continue. C'est une perpétuelle adaptation du système de suivi, évaluation et de surveillance. C'est également un recueil constant et une analyse et l'utilisation des données afin de modifier, le cas échéant, les stratégies et les interventions que nous sommes en train de mettre en œuvre. Alors, nous allons rapidement passer au profil maintenant de digitalisation du Sénégal. Du point de vue de la lutte contre le paludisme, la digitalisation est encore assez timide, comme nous allons le voir, mais il faut juste rappeler qu'au Sénégal, nous avons une politique de digitalisation de la santé. Depuis plusieurs années, il y a eu beaucoup de projets pilotes par rapport à la digitalisation de la santé. Nous avons également un centre de données assez puissant au niveau national, donc localisé à ce qui est appelé la nouvelle capitale du Sénégal, Diamniadio. Donc, ce centre de données va, dans l'avenir, donc nous mettre à notre disposition beaucoup de capacités donc en termes de stockage des données. Nous avons une assez bonne couverture des opérateurs téléphoniques. Nous avons la 3G, la 4G et bientôt la 5G. Et près de la moitié de la population sénégalaise a accès à Internet. Hein, pour être plus précis, il y a 7,26 millions de Sénégalais donc, qui ont accès à Internet. Et le taux de couverture donc, du territoire en termes de débit mobile est de 90%. C'est dire donc que véritablement, donc, nous avons beaucoup de, disons, possibilités par rapport à la digitalisation. Alors, ici, nous sommes sur les investigations des cas. Donc, depuis plusieurs années, nous faisons une collecte digitalisée par rapport aux investigations de cas. Et en vert, vous voyez donc toute la partie du pays qui est couverte en termes de digitalisation. C'est toutes les régions du Sénégal qui sont déjà en préélimination, donc qui font de la collecte digitalisée par rapport aux investigations de cas. Et je dois préciser ici que cette activité est menée de concert avec PAT Donc, une organisation qui nous aide beaucoup dans le domaine de la préélimination. Et vous voyez, nous sommes à 50% de couverture au niveau national. Alors, pour ce qui est de la digitalisation des campagnes de distribution de masse, ici, nous sommes à un taux de couverture du pays de 50%. Vous voyez, ici, c'est toute la partie du pays qui a bénéficié de la digitalisation. Et je rappelle que le Sénégal et la Gambie mènent maintenant, depuis 2 éditions, ce qu'on appelle chez nous une campagne synchronisée de distribution de moustiquaires. Autrement dit, les 2 pays distribuent en même temps les moustiquaires aux populations. Et c'est ce qui nous a valu en 2022 de faire une 2e édition de la campagne de distribution avec la Gambie. Et c'est une expérience extraordinaire et enrichissante pour la première fois. Donc, 2 pays de commun accord ont mis leurs ressources, leurs moyens et tout pour distribuer donc aux populations les MILDA. Et ceci a été véritablement salué par la communauté internationale. Alors, les inspections intradomiciliaires qui sont principalement menées, comme je l'ai dit tantôt, au niveau de 8 districts. Donc là, nous sommes à une couverture de 35,71%. Donc toute cette partie-là, toutes ces régions-là, donc mènent des inspections intradomiciliaires. Alors, ça c'est une diapo simplement de résumé, donc avec les différentes stratégies donc qui sont mises en œuvre et le niveau de digitalisation. Alors, en termes de perspective, nous allons très prochainement, probablement en 2024, pardon, passer à la digitalisation des campagnes CPS. Donc, dès l'année 2024, nous allons digitaliser toutes les campagnes CPS du pays. Je dis ici que nous avons 5 rounds en CPS. On commence au mois de juin et on termine au mois de au mois d'octobre, plus précisément. Nous envisageons également de mettre en place un entrepôt de données d'ici l'année 2025. Comme autre perspective, c'est la digitalisation de toutes nos interventions communautaires. Donc ça, nous allons le faire d'ici 2025. Et enfin, procéder en 2025 aussi à la digitalisation intégrale donc de la campagne de distribution de MILDA. Alors, toujours pour les perspectives, donc de façon plus détaillée, nous allons pour la campagne de distribution de MILDA de l'année 2025. Donc, aujourd'hui, nous avons un disponible de 2400 smartphones, donc avec un gap de 2500. La prochaine campagne, nous allons encore synchroniser avec la Gambie et nous allons la mener au niveau de 5 régions. Pour la PECADOM, c'est la prise en charge à domicile donc des cas. Donc là aussi, c'est une belle expérience que nous déroulons et nous allons très prochainement donc procéder à la digitalisation de la PECADOM au niveau de 35 districts avec 4500 acteurs communautaires. Pour la CPS, je l'ai déjà dit, c'est 16 districts, 5 régions médicales. Donc, une stratégie qui va également être digitalisée avec 2500 acteurs communautaires. Enfin, c'est notre Malaria Data Repository que nous allons mettre en place dès 2025. Donc, c'est une plateforme de visualisation qui va véritablement offrir à tous les acteurs de la lutte contre le paludisme toutes les informations environnementales, les informations pluviométriques, les informations relatives à la mortalité. Donc, toutes les informations seront centralisées dans ce Malaria Data Repository et cette plateforme sera mise à la disposition de tous les acteurs de la lutte contre le paludisme. Voilà donc ce que le PNLP du Sénégal voulait présenter avec vous. Nous vous remercions de votre aimable attention.
Merci beaucoup, Monsieur Latsouk. Donc, on va ouvrir la session aux questions après cette intéressante présentation. Donc, est-ce qu'il y a des questions dans la salle?
Okay. My question goes to Nigeria. First, I want to say thank you for your presentation, especially using the 2 methods for your end process. And I also want to say another thank you to you, but for Senegal, for giving you the opportunity to borrow from them the PPS method. Now, my question is for
your first end process that you did, you said you used a sampling method which according to you was not scientific. And because you use Excel to do your analysis, so you, from your presentation, you didn't give it credence. Now, I want to give you a scenario with Liberia. We also did an end process 2021. We used LQS to do our sampling, and we used Stata to do the analysis. So my question to you then is it because you use Excel to do the analysis, that's why you didn't see that process scientific? Then the next question is, with the second method you use with the PPS, which is the population proportional to size, for your challenge, you still talk about data quality. So can you tell us what were some of the issues with the data for which you still have data quality with the PPS method? Thank you.
D'autres questions par là?
Merci, la modératrice. Je vais poser une question à l'équipe du Sénégal. Merci pour la présentation, pour le partage de cette belle expérience. En fait, je voudrais savoir, en apprenant de tout ce que vous avez réalisé, quel est le mécanisme de centralisation des données pour les analyses, l'utilisation entre les zones couvertes par la digitalisation et les données collectées par sur version papier dans les zones non couvertes. Comment vous arrivez, quel est le mécanisme pour mettre les données ensemble pour avoir une base pays? Et la deuxième question, c'est par rapport à la digitalisation de la campagne de distribution des masses dans 50% du pays, sur le plan géographique. Quelles sont les données qui sont digitalisées? Quels sont les dénombrements, distribution et gestion de la chaîne logistique au niveau, à tous les niveaux, des entrepôts jusqu'au site de distribution, où il y a aussi les données de visite à domicile post-distribution. Donc, vous voulez juste savoir à quelle phase les données sont digitalisées. Merci.
Merci.
Alexis, ma question va au Sénégal. Le Sénégal semble avoir pris le taureau par les cornes pour ce qui est de la digitalisation. Je voudrais savoir quel impact net pensez-vous observer entre la période avant digitalisation et la période pendant digitalisation? Merci.
Il y a une question au fond.
Merci beaucoup. Je remercie l'équipe du Sénégal. Et il y a les présentateurs qui viennent de dire encore une fois en précisant qu'ils publient hebdomadairement les bulletins épidémiologiques, alors que les données, selon l'explication, les données sont envoyées au niveau de DHS2. Mais là, quand est-ce que vous validez toutes ces données-là? Parce que ces bulletins-là est imprimés, à moins que ça puisse être en version électronique. Si c'est imprimé de façon hebdomadaire, quand est-ce que vous validez toutes ces données? Ou au cas où vous remarquez qu'il y a des données aberrantes, vous faites comment? Merci.
We have two questions here, so we're going to share. Thanks to both groups for the presentation. My question is for Nigeria. I was interested to see the segmentation process with Google Maps and was wondering if you've had any observations of potential bias in the way that we zoom into those segments to find those 15 houses, if people focus on like clusters of houses, and then whether you've noticed that that's different from the way that the segmentation process may have been biased previously before the Google Maps approach. Thanks.
Merci beaucoup. Je suis Roch Aïpon du PNLP Bénin. Ma question va au Sénégal. Elle est exactement celle-ci. Je voudrais savoir quelle est la plus-value ou l'avantage qui réside dans l'organisation conjointe de la campagne MILD avec le pays voisin, avec la Gambie, je veux dire. Et la deuxième question, j'ai vraiment apprécié la fréquence de publication de vos bulletins sur les indicateurs PALU issus du DHS2, mais je voudrais savoir à quel moment ces indicateurs sont validés pour être publiés, ou bien ce que vous publiez, ça remonte de combien de temps? Merci.
Je pense qu'on doit donner le temps aux équipes de répondre. Peut-être on prend les deux dernières questions et
Okay. Thank you. Thank you. It's not working.
Hello?
It's not working. Hello? Hello? Can you hear me?
All right. My question is to the Nigeria team. You did mention that the CMTs are supposed to be independent monitors, but during your presentation, you also mentioned that they are selected by the states. So I'm trying to wonder how the implication of bias, because if there are state personnel, they are selected to do end process in their own states, I think it's inevitable to have people that will not be biased in the process.
okay, une dernière.
Okay, thank you very much. My question goes to Nigeria presenters. During your presentation, we have mentioned that there are some households missed during the registration. So in that sense, probably those houses missed during the registration, they were not given it. So what action did you take to ensure they are going to be benefited after completion of that distribution? Thank you very much.
Merci beaucoup. Je vais laisser l'équipe du Nigeria répondre d'abord et après le Sénégal. À vous.
Yes. Thank you, everyone, for the audience, and also thank you for the questions. I hope you can hear me. Okay, so the first question was on the use of Excel and why we considered our first methodology as unscientific. It's actually not because of the use of Excel, it's because of the selection process. Because remember, basically what we did then was just to identify 4 LGAs, 4 words in every LGA. And then within those 4 words, 10 households are identified. 10. Okay, 10. Yeah, so 10 settlements are selected, and within these settlements, 10 households are sampled for the end process. So unlike what we are doing currently, the selection process that we actually made reference to when we talked about the process not being scientific. And then the other thing is the Excel analysis we used to do then was not at the individual data level. Like I mentioned during the presentation, what we did was to summarize the data per word. And there's a summary data that is imputed into the template. So in the process, some of the information or some information you would have been able to get at the individual level of analysis are lost. You don't get those. So that's also why we appreciate the use of Stata in the current process we do. Then going to the next question on the data quality issues with the DPS. Yeah, I'm not sure. I remember the question. No. Before that, there was a question on. Okay, maybe I'll come back to that. So on the other question on bias segmentation process. Yeah, so like the only difference in the segmentation that we do compared to use of the conventional map It's just that we use the segmentation is not on Google Map. So it's the same process where you divide the boundaries into quadrants, randomly pick one quadrant, zoom into it, divide it further, and keep repeating the process until you see 15 to 20 households. So I don't think it's, in my opinion, I don't think he has introduced any bias. Yes. So because we basically follow the same principle, just that the process is done on Google Map, not on the conventional map. Then so selection of CMTs by the state. Well, it's because I think that's what we have in our guidelines in the campaign mission guideline. I hope I'm right. Yeah. Okay, maybe I can leave that to Fatih to answer.
Thank you. So there's a criteria for selection of the personnel, and it points you towards getting CMTs that are as independent as possible. But because we allow the state to, adhere to this personnel selection and provide them, you tend to get political interference, because at that state level, they are also answerable to political leaders. So the criteria itself is independent, but it's the adherence that we have problem with. And then the other question on some households that were missed during campaign. So because the campaign has ended, and this is presented at the end. Okay, during implementation, missed households as much as possible are encouraged to have a revisit, to go back, and then during mop-up also, they go back to such areas to mop them up. But then again, you manage to miss some households at the end. So these areas are presented to the state. If there are leftover nets, they can use those nets to cover that area. And then some states have other interventions like Saving 1 Million Lives, where they're able to purchase their own nets. And based on our recommendation, they can refer to those households and areas that were missed to follow up. Thank you. If you want to add anything.
So I think maybe the response, let me see the response I will provide to the other question. Will address the concern of the person that asked the question. Yeah. So when we want to do the PPS, when we do the selection using PPS, what we normally do first is to discount the wards that have security issues, because we don't want to select a location where there's a security challenge and then send someone there. So we discount those places, those wards that we know have security issues, and then do the process without including those wards. So they are excluded from the selection process. So because we don't want situation where maybe if you select out if a location that has security challenge selected, you may be forced to jump it or not adhere to the process as it should be. So we before we start the process, discount those ones and then run the process without including them. Thank you.
J'ai une dernière question en ligne pour le Nigeria. Si vous pouvez prendre le casque pour suivre la traduction. Donc, c'est Zainaba Ali qui pose. Merci à l'équipe du Nigeria. Pouvons-nous avoir des clusters au sein d'une même circonscription? Si oui, est-ce qu'ils seront utilisés tous les deux ou est-ce qu'un cluster sera changé? Et à partir du processus final, lorsque l'endroit est difficile d'accès, l'équipe de suivi de la campagne s'y rend-elle toujours ou change-t-elle de cluster? Vous avez compris la question ou je répète? I repeat or it is okay? It's okay. Pouvons-nous avoir des clusters au sein d'une même circonscription? Si oui, est-ce qu'ils seront utilisés tous les deux ou est-ce qu'un cluster sera changé? La deuxième partie de la question, c'est à partir du processus final, lorsque l'endroit est difficile d'accès, l'équipe de suivi de la campagne Seront-elles toujours ou changent-elles de cluster? It's clear?
Okay, yes, so when the selection process results in a cluster falling within, maybe more than one cluster falling within one ward, yes, we work with the two clusters within the ward. So what we do is for the segmentation stage, rather than dividing the quadrants or divided by quadrants, we'll divide by 8 so that one of if you divide the map boundary by into eight quadrants, into 8 sections. So we use the first 4 sections to do segmentation for one cluster, and then we use the other one for segmentation for the other cluster. So if more than one cluster falls in within the same word, we still work with that. Then the second one is okay, so for hard to reach area, the only one we discount is security challenge areas. But if it's hard to reach, we still select the location. But we usually try to make provision because we know it's going to be more expensive for the person posted to those locations to get there. So we make additional provisions for such locations so that they can get there.
Merci. L'équipe du Sénégal, on a un peu du retard dans le temps, donc.
Merci,
Et pour la synthèse.
Voilà, je vais rapidement répondre aux interrogations. Je voudrais d'abord remercier l'intérêt donc qui a été manifesté par les uns et les autres, donc par rapport à la présentation. Pour les questions qu'elle a soulevées, donc il y a une question qui est relative à la plus-value, qui réside dans l'organisation synchronisée avec la Gambie de la campagne. Donc je pense que ici, la campagne n'a en réalité été que le prétexte. La synchronisation avec la Gambie nous a permis de renforcer notre collaboration transfrontalière. Aujourd'hui, en dehors de la discussion de masse de moustiquaires, nous allons vers l'organisation simultanée et synchronisée de la CPS avec la Gambie, par exemple. Donc, ce fut qu'un simple prétexte. Maintenant, toute la problématique de la lutte contre le paludisme va être prise en charge de façon commune avec la République sœur de Gambie. Voilà donc véritablement la plus-value, donc la plus palpable, donc du point de vue de la collaboration transfrontalière. Pour la fréquence de publication des bulletins et la validation, donc comme je l'ai dit, le bulletin hebdomadaire, il est produit tous les mardis. Le bulletin annuel, il est diffusé tous les ans au mois de février. Alors, pour un peu prendre en charge, c'est une autre question, pour un peu prendre en charge toutes ces données-là et régler le problème des incohérences, des aberrations, etc., nous avons au niveau national un système de points focaux. Nous avons 14 régions médicales. Et nous avons au niveau du programme, au niveau central donc, 14 points focaux qui sont chargés de faire un suivi quasi quotidien donc du DHS2 pour leur région. Donc, ils sont là que pour ça. Et chaque fois qu'ils identifient des incohérences ou des aberrations, ils appellent directement la région concernée. Et la région concernée appelle le district concerné. Et on règle ces problèmes d'incohérence et d'aberration donc de cette manière-là. Ce qui nous a permis d'avoir, disons, des données pour les années antérieures à 2022, parce que pour 2022, on a eu des problèmes avec les prestataires de services qui sont entrés en grève et tout. Donc, pour l'année 2022, on n'a pas encore stabilisé nos données, donc du fait de ces mouvements de grève-là. Mais pour les années précédentes, voilà donc le système que nous avons mis en œuvre. Donc, c'est les points focaux qui accomplissent un travail extraordinaire. Alors, une question relative à l'impact net avant la période de digitalisation et après la période. Le plus grand impact, c'est l'instantanéité de l'information. Au niveau des postes de santé, l'infirmier chef de poste avait à sa disposition toutes les informations à l'instant T. Donc ça, c'est un résultat, une plus-value extraordinaire parce qu'il peut prendre des décisions quand il voit des choses qui ne vont pas. Par exemple, pour la digitalisation, nous avons la géolocalisation qui est faite. L'infirmier chef de poste dans son bureau, il peut apprécier si tous ces ménages ont été touchés. S'il y a des ménages qui ne sont pas touchés, il peut appeler directement les équipes qui sont sur le terrain, qui vont naturellement donc prendre en charge ces ménages qui n'ont pas été pris en charge. Alors, une question donc relative toujours à la campagne CU Milda. Ici, je dois préciser pour cette question que la digitalisation, elle est faite pendant tout le processus. Donc, recensement, distribution, hein, et même validation. Donc, de ce point de vue, il n'y a pas de problème, tout est digitalisé par rapport donc à cette question. Alors, pour les mécanismes de centralisation des données, pour les investigations, par exemple, je l'ai rappelé, nous travaillons principalement avec PAT. Donc, cette organisation donc, a mis en place un DHS tracker. Donc, là, c'est le DHS tracker qui nous permet donc d'avoir toutes les informations. Et je rappelle que le DHS tracker est interopérable avec le DHS national. Donc, de ce point de vue également, il n'y a pas de problème. Je pense que j'ai essayé de vous satisfaire hein, par rapport à la tyrannie du temps. Merci beaucoup.
Merci beaucoup. Je pense que c'est une belle introduction pour le 2 jours qui arrivent sur la digitalisation, la présentation du Sénégal. Donc, vous aurez l'occasion de poser les questions pour le 2 jours qui arrivent. Là, on va aller vers les Amériques. On aura une présentation sur le suivi programmatique des MILDA pour l'action qui sera faite par Licia Fernandez. C'est une présentation en ligne. Je vais demander à l'équipe de rester parce que la Guinée va être seule. Donc, si ça ne vous gêne pas, vous pouvez rester avec la Guinée. Parce qu'il n'y a que la présentation de la Guinée. Donc, it's okay? The Guinea will only if you can stay with him, it is okay. Okay. Okay.
Everyone, I want to thank the organizer for this invitation. My name is Roberto Montoya. I am the regional advisor for malaria in the Pan American Health Organization. I'm going to share this presentation with Lucia Fernandez. Lucia works with the Clinton Health Initiative as advisor for vector control in our region. We're working together on the implementation of this approach in malaria endemic countries in America. The next one, Lucia, please. Let me start with some contextual information. In the Americas, we have 18 malaria endemic countries. We have several countries that are very close to eliminate malaria, but also some countries that are still facing important challenge with the disseminated transmission. Indigenous people, migrants, mobile populations, and miners, agricultural workers are among the most affected communities in our region. And we have several challenges in terms of vector control, particularly associated with vectors that are exophilic and outdoor transmission. Next slide. We have an important challenge in terms of coverage and use of nets in the region. Washing practice is, for example, one of the key challenges related with the use of mosquito nets. And the number of mosquito nets in our countries is much smaller than in other regions. You can see here, for example, the situation in Panama, a country that distributed only 20,000 nets in the past year. This is why large-scale surveys are not relevant for us. We need a more operational monitoring and evaluation approach, an approach that allows the field teams to take decisions in the local level. Next slide. It's in that context that we became interested on the use of quality assurance sampling for monitoring mosquito net use. I have to say here that it was actually a reference that we found in the AMP toolkit what motivated us to explore this approach. The method was designed in the 1920s to evaluate the quality of a lot in the industry using a small sample of products. In that approach for the industry, it was important to evaluate all the lots. And that is actually what is also important for us. In the context of malaria, it is about evaluating all the foci, not only to obtain a general estimation. That is, in my opinion, the most important similarity that we found between this approach and our needs in malaria. 19 is the magic number in this methodology. 19 is the smallest sample size that allow high sensitivity and specificity. The sample of 19 will give the manager a high probability of rejecting substandard lots. In malaria, it is about the capacity to identify, for example, foci with critical problems in mosquito nets use. The next slide, please. We worked then on the adaptation of this methodology to mosquito nets monitoring. The objective is to generate programmatic data to trigger actions using a method easy to implement by local teams. The approach has been used in other countries. I would say with some inconsistency in the methodology. And this table is the translation of the terminology from the industry to the mosquito nets monitoring. The key part, in my opinion, is here, the lot. You can see how in the lot in the industry correspond in our malaria approach to the supervision area. This is like a focus or cluster of localities or operational unit. Next slide. There are basically two levels for the sampling process and the analysis. And the information that the methods provide is different for each one of those levels. One level is the supervision area, here in red, which corresponds to the lots in the industry approach. This is like a focus or cluster of localities for us in malaria. At this level, the method only will tell you if the area is significantly below a set threshold. So if the area will need an action, no estimates will be obtained at this level. The other level is the area of interest. It is like a municipality or district in our approach. It is the one which is here in the map with the white border. At this level, the method will provide a quantitative estimate for each one of the indicators. To obtain a good confidence interval will be necessary to have at least 5 supervision areas. In this example, that actually is from an exercise done from Lucia in Honduras, we have 7 supervision areas. Here is when we use the magic number, the 19. In each supervision area, we sample only 19 households or 19 mosquito nest users. In this example, the total is 113 for all the municipality. So I'm going to stop here, and Lucia is going to explain the indicators that we are measuring and additional details of the methodology. Over to you, Lucia.
Thank you, Roberto. So as Roberto was saying, at the supervision area level, we can only say if a supervision area is well below a target or is on target. So that's why it's very important to define first our indicators of interest, the ones that we want to measure, and then our target for each of these indicators. So taking the example of the LLIN use indicator, so percentage of people sleeping under a net the night before. Imagine a country that has set a threshold or a target of 80%. They want to reach 80% use. In that country, they will need to go to these 19 households and ask this question to one member in each of the households. Did you sleep under a net the last night or the night before? And then in order for the area to be considered as on target, 13 of these people will have to answer yes. And how do we know it is 13? This is the table that allows us to know what is the number of people or the number of households or the number of nets, depending on the indicator, that should be answering affirmatively to the question in order for us to consider the supervision area on target. So in this case, we have a sample of 19 households, so in this case, 19 people, and the country is aiming for 80% use. So they know they have to reach 13 people answering yes to the question. And so the same applies to access. For example, if here they are aiming for 90% access, then they know it's 15 people that will have to answer yes, I have access, or 15 households that will need to have enough nets to cover all the sleeping spaces. And the same logic applies to all of the indicators. So as you would have seen from the table, we have household-based indicators, we have people-based indicators, and we have net-based indicators. And Roberta was saying that we need to sample 19 households. In order to get also 19 people and 19 nets, so always 19 units to calculate our indicators, then what we are proposing to do in this methodology is to select one random person from each household and one random net. And this is an example of a tool that could be used in the field to select one random person or net from the household. At the area of interest level, there is two other things that we can calculate with this methodology. On the one hand, we have physical durability. And basically, this means that we will have to run this monitoring survey 3 times in order to have enough data points to estimate net durability. And this will also be easier for countries that have a census of households and that have collected household-based data during the campaign. So they know how many nets they gave to each household. That will be much easier. For countries that do not have that information, they will have to ask households how many nets they received. And because not everyone remembers, this will be subject to like recall bias, and it may be less precise. But still, it can be done, just aware that the precision of the estimate may not be that good. The other thing that we can measure is bioefficacy. So most programs don't have the capacity to run bioefficacy assays on 19 nets from each supervision area. That will be too many nets. So where the methodology proposes is to measure bioefficacy per area of interest. So aiming to get between 20 and 30 nets for each area of interest, which normally would mean collecting 1 to 5 from each supervision area. And then just estimating bioefficacy at this area of interest level. And in countries with very little capacity, but still with some capacity to do bioefficacy, maybe they can do bioefficacy testing in just one area of interest, or 2 areas of interest instead of in each area of interest of the country. This is an example of how we could be sampling these households in the field. So in countries that have a census of the households, this is easy because they can just randomly select 19 from each supervision area. But in countries that do not have a census of the households, this will become a bit more tricky. And this is an example of how it could be done. So field workers could start from a specific point in the supervision area, then turn a pencil on the floor or on top of a notebook, and then start walking in the direction that the pencil is marking, and then selecting 1 out of 5 houses. So every 5 houses, they select 1, and they do the monitoring survey in that 1 house, up until they have all the 19 households that they are supposed to get in the end. And to make it easy for field workers to remember where they have to take nets for bioefficacy testing, because as we were saying, countries cannot analyze 19 nets, so they will just take a few from each supervision area. Eventually, the houses from where the nets should be taken could be defined beforehand. So for example, a country could say, I am going to take a net from household 1, 5, 10, 15, and 19 in every supervision area. So it's a fixed rule and easy to remember. And those are the ones with the green circles around it. So how do we use the data for decision making, which is probably the most important thing of all of this? This is an example of the results for 4 different supervision areas in a country. This is invented, so it's not a real example. It's just for the purpose of this presentation. And if we see the supervision areas that have not met at least one of the targets, have here action required, meaning that the program needs to take an action to solve the problem they identify in that area. So if we look at the first supervision area, we see that this area has met the access target, it has met the physical condition, or physical integrity target, and the washing and drying practices, but it has not met the LLIN use target, meaning that the Ministry of Health here has to really focus on increasing use, which could be done by implementing SBCC campaigns, for example. In contrast, the second supervision area has met the access target, the use target, but has not met the physical condition target and the washing and drying target. So in this place, people are using the nets, but nets are not in good condition. So in this case, in this area, the Ministry of Health, the malaria program, could be either aiming at replacing the torn nets, or maybe doing the next campaign a bit earlier if these results are obtained close to the end of the lifespan of the mosquito of the campaign. And it should focus as well on doing SBCC to improve washing and drying practices, to make sure that people wash and dry the nets according to the recommendations, and so on and so forth. So it gives you, for each supervision area, what is the important things to focus on for the program to work on. Just to say that CHA is helping PAHO to implement or to pilot this methodology in at least 2 countries, hopefully 3, and we will be starting from Honduras. So in Honduras, we've helped the program to develop a protocol, SOPs, and a data collection form. And my colleagues are currently this week testing and validating all of the SOPs and data collection forms in the field. The idea is to apply the methodology, extract some lessons learned, and develop materials that then can help PAHO to finalize, refine and finalize this technical guideline that they were developing, where they are describing the methodology that we just presented in this presentation. So anything that we find out in these pilots will enrich this document, and also the materials that will be developed, like SOPs, like data collection forms, like tools to select households, may end up being annexes to this document as well. Also, very important to say that PAHO is expecting feedback, and Roberto can mention or comment more as well. But any of you who has any comments, any concerns on the methodology, please send your comments to PAHO. They are very, very welcome, as we hope to have a very robust methodology in the end. So that's it. I'll open the floor for questions now, and thanks a lot to everyone for listening.
Merci à l'équipe de l'initiative de Clinton pour l'accès à la santé. Donc, Licia est en ligne, donc quand on va ouvrir la session pour les questions, vous pouvez poser les questions. On va enchaîner avec la présentation de la Guinée, intégrer la prestation de services, l'approche pool aux populations difficiles à atteindre, les principaux résultats et les recommandations futures. Monsieur Christian va présenter. C'est là.
Je crois que je vais présenter en principe, cette présentation devait être faite par le premier président de la Guinée, mais pour des raisons indépendantes de leur volonté liées à l'emploi du temps surchargé, ils n'ont pas pu se déplacer. Donc, je suis là comme leur messager. Je vais présenter. J'espère que tout ce que je vais dire sera fidèle à ce qu'on m'a dit de dire. Alors, l'expérience que voudrait partager la Guinée, ça va changer un peu le temps, parce qu'ici, il s'agit de montrer comment la mutualisation des campagnes pourra aider à améliorer, n'est-ce pas, les indicateurs de santé. Alors, plusieurs raisons ont poussé la Guinée à passer à la mutualisation des campagnes. Et dans le cas précis de la Guinée, ils ont intégré l'année dernière la campagne de chimioprévention du paludisme saisonnier avec n'est-ce pas, le programme élargi de vaccination. Et ce qui a poussé à faire ça, c'est que effectivement, la plupart des campagnes organisées au niveau de la Guinée font face à des difficultés et parfois à de multiples interférences, parce que c'est le même cible qu'ils utilisent, c'est les mêmes acteurs qui sont également utilisés. Et d'autre part, il y a eu des points recensés au niveau des ménages par rapport à des multiples interventions qui se passent à des échelles, à des fréquences très, très rapprochées. Également, la diffusion des rumeurs qui tournent autour, n'est-ce pas, de cette idée complotiste, peut-être pour rendre les enfants par-ci, par-là, bon, ça, c'est pas de rumeurs. Et les deux groupes, qu'en se mettant ensemble, ils pourront juguler ce type de rumeurs. Et également, l'opportunité qui avait été donnée avec la CPS à travers la visite à domicile, parce que la CPS, c'est de porte à porte. Et on se dit que c'est une opportunité qu'on peut saisir, n'est-ce pas, pour en même temps améliorer les autres indicateurs de santé en incluant dans le paquet la vaccination, le paquet lié à la santé de reproduction. Et l'intérêt dans la mise en œuvre de cette stratégie, effectivement, c'est que les sources seront mises en commun. Il y aura un gain de temps, évitant ainsi des retards qui sont accusés parce qu'on doit reporter dû à des conflits d'agenda. Et également, améliorer l'efficience et les indicateurs, comme j'ai dit tantôt. Alors, en ce qui concerne le déroulement de l'activité, cette activité a été portée l'année dernière dans 10 districts de santé sur les 17 où on met en œuvre la CPS. Il s'agit de districts dans 5 districts dans la région de Labé, 2 dans la région de Béké et 3 dans la région de Mamou. Et j'ai dit tantôt que c'était le même cible. En fait, pour le cas de la CPS, c'est les enfants de moins de 5 ans. Et alors qu'on retrouve également au niveau de la PEV les enfants de moins de 5 ans et les femmes enceintes. Donc, la mise en œuvre a demandé l'appui et l'implication de presque tous les partenaires financiers et techniques, parmi lesquels vous verrez le ministère, les unités du ministère de la Santé, également les divisions provinciales de santé, ainsi que les partenaires comme l'OMS, l'UNICEF et d'autres. Et le s'est passé en plusieurs phases. La première phase, c'est la phase préparatoire qui a consisté d'abord à des réunions virtuelles liées au contexte COVID depuis 2021, dont des discussions sont entamées pour essayer de voir comment se fera la faisabilité de cette stratégie. Effectivement, il y a également ces partenaires qui sont mis ensemble pour développer la stratégie en question et qui a conduit à la micro-planification parce que les populations, comme vous le savez, on a eu une présentation ici qui a une divergence des populations selon les programmes. Le programme PF qui vient avec une population, le programme CPS qui vient avec d'autres populations, mais les deux programmes se sont assurés pour s'entendre sur les populations à considérer pour la micro-planification. Et il y a également effectivement des plaidoyers pour sensibiliser, que ce soit au niveau central ou au niveau régional et au niveau périphérique de tous les acteurs. Il y a effectivement, comme c'était une stratégie combinée, il fallait concevoir et développer les outils adaptés à cette nouvelle stratégie, former les acteurs pour qu'ils n'est-ce pas, s'acquièrent de cette nouvelle stratégie et préparer et acheminer les outils et tous les intrants au niveau périphérique. Donc, une activité importante, c'était effectivement l'exploitation des fiches de vaccination au niveau des centres de santé pour essayer de détecter les perdus de vue, que ce soit pour la vaccination ou pour la CPN ou bien pour la distribution de routine. S'agissant de déroulement, il y a eu plusieurs phases. La première phase, n'est-ce pas, consistait à la distribution des médicaments de CPS aux enfants de moins de 5 ans, l'identification des femmes enceintes et des enfants et des femmes enceintes à rattraper à la vaccination également. Et cette phase pouvait durer, a été planifiée pour 5 jours et c'était suivi de la collecte, l'analyse des données et la planification et également de la sortie des équipes de rattrapage. Et cette sortie de rattrapage des équipes de rattrapage se faisait à partir de la deuxième journée, effectivement, pour essayer d'aller dans les ménages, retrouver les femmes qui sont passées par la CPN ou bien qui ont reçu les TPI, ainsi que les enfants qui n'ont pas reçu des moustiquaires, des routines et autres. Donc, j'ai parlé de rattrapage des CPN, également la collecte et remontée des données, et cette séance a duré 6 jours. Et la synthèse de toutes ces données s'est faite au niveau des centres de santé, au niveau des directions provinciales de santé et de l'inspection régionale de santé, ainsi qu'au niveau national. pour que ça marche, pour que les choses se passent de manière efficiente, les rôles ont été bien répartis. Au niveau périphérique, nous avons eu des superviseurs de proximité qui avaient pour tâche effectivement d'assurer la coordination étant donné de nombreuses organisations et partenaires impliqués, ainsi que les équipes de distribution. Et ils ont également assuré, ils avaient pour rôle d'assurer la supervision de proximité, de former les relais communautaires et tous les agents impliqués et également de veiller à la saisie et la remontée des données. Par contre, également, nous avions 3 équipes dans lesquelles on avait, par centre de santé, on avait 3 équipes et dans chaque équipe, on avait 2 agents, une personne en charge PEF, l'autre en charge de CPN. Et ceux-là avaient pour rôle de répertorier les fiches en souffrance de vaccination ou de CPN, également de les classer par village ou par secteur, de préparer les intrants et les outils à acheminer et d'assurer, de programmer le rattrapage des cibles PEV et CPN. Dans ces équipes, il y avait un troisième agent qui avait pour rôle d'assurer la recherche active des cibles pendant que la discussion se faisait et assurer également la sensibilisation et le remplissage des outils. Alors, sans trop de temps, je vais passer au résultat. Qu'est-ce que ça a donné tout ce scénario? En fait, lorsqu'on regarde l'objectif de la CPS, on avait peur que cette mutualisation ne puisse affecter, mais effectivement, c'était meilleur parce que lorsque vous regardez les résultats du premier passage au 4e passage de CPS, tout est bon, on atteint les objectifs de plus de 100%. Et également, par rapport aux enfants qui ont pris les 4 passages, on regarde également près de 95%, ce qui montre que la mutualisation est possible, n'a pas affecté la CPS. De l'autre côté, lorsqu'on jette un coup d'œil sur les femmes enceintes rattrapées pendant ces CPS liées à cette mutualisation, on constate également que lors de la CPN à CP4, il y a eu des femmes qui n'avaient pas passé au CPN, qu'on a soit référées, sensibilisées à aller et qui effectivement sont allées et vous pouvez voir le pourcentage affiché. Avec le CPN4, on était jusqu'à 91%. Également, ces femmes référées, pour la plupart, prenaient les TPI, que ce soit TPI1, TPI2 jusqu'à TPI4. Et vous pouvez également constater avec la TPI4, on était jusqu'à 82%. Également, on poussait les femmes enceintes à prendre, pour ceux qui n'ont pas reçu le vaccin antitétanique, de les récupérer. Là, vous allez voir que le résultat était bon, seulement on s'est rendu compte qu'on n'a pas eu le résultat escompté avec les TD5. Peut-être que là, l'analyse, peut-être l'équipe qui est en ligne actuellement et qui me suit pourra apporter des éclaircissements là-dessus. Et j'ai aussi quelqu'un dans la salle qui a passé sur le terrain. Donc, également, il faut noter que tous ceux qui vont aller à la CPN et qui n'avaient pas reçu des mousquets les recevaient. Mais en plus, il y avait des gens qui ont fait bien le CPN, mais qui n'avaient pas reçu les moustiquaires. On a pu identifier près de 648 femmes qui n'avaient pas reçu les moustiquaires, mais qui, à travers ces stratégies, ont pu recevoir, dont 69% de celles-là ont pu recevoir leur moustiquaire CPN. En ce qui concerne les résultats PEF, c'était similaire à ce qu'on a observé à la CPS, à l'exception de la BCG où on a observé 9%. Il y a eu beaucoup de réticences, également parfois liées à l'acheminement des produits qui ne sont pas arrivés dans certaines zones enclavées, donc ils ne pouvaient pas. Et également, il y avait une politique qui consistait à ce qu'il faut 20 personnes pour qu'on puisse ouvrir une boîte de PCG. Lorsqu'ils n'ont pas atteint ce nombre, il y avait le retard. Et au moment où les données se collectaient, donc, il y avait cet écart-là. Et vous pouvez observer qu'avec la polio, on est arrivé jusqu'à près de 87%. Alors, en ce qui concerne les défis liés à cela, il y a eu un défi de coordination étant donné le nombre d'acteurs impliqués. Honnêtement, ça a demandé une bonne stratégie de coordination qui n'a pas été toujours très facile. aussi avec les partenaires et tous les acteurs locaux, les acteurs de la société civile. Également, l'acheminement, comme j'ai dit tantôt, des médailles, des vaccins et outils jusqu'au niveau périphérique. Dans certaines zones, c'est tellement enclavé. C'est pourquoi vous avez vu les BCG aussi et d'autres vaccins contre la méningite qui étaient un peu affectés par ça. Également, il y a eu ce problème d'adhésion des bénéficiaires à l'initiative. Ce n'est pas toujours facile. Il faut renforcer la sensibilisation. Également, on a noté que quel que soit, même quand les deux programmes se sont mis ensemble, il y a eu pendant la budgétisation des demandes supplémentaires et supérieures à ce qu'ils avaient comme budget et au financement des bailleurs. Donc, du coup, ça a nécessité des réajustements. Donc, il y avait ce problème de mobilisation des ressources supplémentaires pour la mutualisation. Comme recommandation, le pays pense qu'il faut faire un plaidoyer auprès de l'État en faveur de la mobilisation des ressources pour le financement des CPS et l'achat des moustiquaires. C'est ce qu'on a observé pendant cette stratégie. Également, il pense à l'extension de la mutualisation à tous les districts de CPS, intensifier la sensibilisation de la population pour la mutualisation des campagnes, et également passer à la digitalisation des données de la mutualisation au niveau communautaire, parce que tout ce qui s'est passé encore sur les copies dures ou bien sur Excel, ce qui n'était pas très approprié. On pense qu'il faudrait passer à la digitalisation. Et comme leçon apprise, la mutualisation des campagnes santé est possible pour améliorer la couverture et les indicateurs de santé. La mutualisation des campagnes est coefficace et permet une utilisation optimale des ressources. Cette mutualisation réduit les retards accusés dans la mise en œuvre des campagnes, effectivement, comme j'ai dit, à cause des conflits d'agenda des programmes de santé qui utilisent presque les mêmes acteurs, les mêmes cibles. Et enfin, ils pensent que la mutualisation des campagnes est une piste de réflexion pour la campagne de routine de MILDA, pourquoi pas en alternative à la campagne classique de masse de MILDA. Donc, je crois que j'ai essayé d'être le plus fidèle possible compte tenu du temps et que la Guinée va me pardonner si je n'ai pas dit tout ce qu'ils m'ont demandé de dire. Et c'était là la quintessence de la présentation. Merci.
Merci, M. Christian. La synthèse et pour cet partage d'expérience très intéressant. On va ouvrir la session aux questions. Donc, y a-t-il des questions dans la salle? J'ai l'impression que tout le monde a besoin du café. Ça va être après cette session. Donc, quelques minutes et on va aller en pause.
So my question is for Lucia, who I think is online. So thanks for that presentation. I think a few of us were excited to see the elements of net durability that you're including in the LQAS. And while it's true we need to account for recall bias in the number of nets that households received, I may have missed or maybe would like more clarification on whether you're planning to calculate attrition at these households and in the context of the LQAS, how you're planning to go about that. I think we're all looking for options for more rapid and lighter durability monitoring, and this is maybe something that would be suitable in a number of contexts. Thanks.
And thank you, everybody, for the presentations. My question is actually for Christian. I understand that we get, time savings and we get some cost effectiveness. You've referred to, the need to sensitize the communities, but my question is really about the payment for the community health workers that you used and how they reacted to receiving one payment for multiple activities when previously they would have been paid separately for each intervention that they were delivering, and how you manage that that aspect of the integration. Thanks.
Pas de questions dans la salle en dehors de ces deux questions? OK. Je pense que Licia est en ligne pour la première question. Je ne sais pas si elle nous entend. Peut-être on commence par la dernière question, le temps que Licia nous reçoit. Donc,
Je l'ai dit tout à l'heure, je crois que c'est une très belle question en ce qui concerne le paiement des relais communautaires par rapport aux deux inventions qui se mettent ensemble. Ils auraient souhaité certainement recevoir, comme ils ont l'habitude, des différents programmes. Mais je voudrais, pour être plus clair, donner la parole à Donatien, qui est basé en Guinée, qui est de CRS Guinée et qui a participé à l'activité d'apporter la réponse à ça. Merci.
Merci, et Christian. Je vais apporter les éléments de réponse. Comme vous l'avez dit dans la présentation, la mutualisation est coût efficace. Donc, l'un des objectifs de cette intervention est nécessairement de réduire les coûts. Parce que les personnes sont payées par le nombre de jours prestés et non par le nombre d'actes posés au cours de la journée. Donc, la CPS prend pratiquement 5 jours et c'est au prorata de cette durée que les personnes sont payées. Mais elles sont aussi formées, sensibilisées, conscientisées parce que ces personnes sont issues de la communauté. C'est leur communauté qu'elle est en train de servir. Donc, cela fait partie aussi de leur travail quotidien, comme certains d'entre eux sont des relais communautaires. Donc, en termes de ressources, il y a quand même certaines économies, il y a quand même une réduction de dépenses parce que les activités se mènent au cours de la durée définie. Donc, et non par paiement par acte. Donc, voilà ce que je peux être. Mais ce qu'il faut ajouter ici, que les ressources sont utilisées en augmentant le nombre de personnes par équipe, parce qu'il faut au moins 2 personnes qui sont formées sur la vaccination, parce qu'on doit récupérer les enfants qui sont en retard avec leur calendrier vaccinal. Mais en termes de durée, le reste la même. Là, les ressources sont mutualisées.
Merci. Merci. Je pense que Licia va répondre à la première question, donc je vais lui donner la parole.
Hello, good morning, everyone. Do you hear me properly?
Yes.
Perfect. Thanks so much. Thanks, everyone, for listening to our presentation, first of all, and thanks, Hannah, for your question on attrition. The answer is yes. We are planning on also calculating attrition. So basically, we are including 3 questions or 4 questions in the data collection form. One is the number of nets received during the campaign, then the nets still in the household today from the ones received in the campaign, how many nets were given away to other people, visitors, relatives, any person, and how many were lost to other reasons or basically used for other purposes. As we were piloting or validating this methodology in Honduras, we realized that people are receiving nets from Honduras and from Nicaragua because there is quite a lot of mobility across the borders. So for now, we've decided that because they receive different brands from the different countries, the field workers will be checking the label of the net to make sure that when we ask the questions, they count the number of nets that were really distributed by Honduras. So we're like just refining the last few things to make sure that we count properly, but the idea is to measure attrition through this survey. We also realized during this validation in Honduras that people did recall quite well the number of nets they received apparently, so that was quite good news, but it had been 1 year since they distributed the nets, so not that long ago. But yeah, we're still refining a few things, but we hope to be able to calculate attrition during the surveys. Over.
Merci, Licia. j'ai une dernière question en ligne pour la Guinée. Vous l'avez dit, un des défis, c'est l'adhésion des bénéficiaires. Est-ce que vous avez fait concrètement en termes de sensibilisation pour élever ces défis? Qu'est-ce qui n'a pas marché dans l'intégration?
Bon, en fait, toutes les communications, un plan de communication avait été élaboré pour intégrer la stratégie et continuer à sensibiliser sur la CPS et la vaccination. Cependant, il y a eu quand même des résistances qu'on a observées. Cette résistance peut-être est mineure, mais c'est quelque chose qu'il faut renforcer davantage. Donc, il y a des parents qui jusqu'à aujourd'hui s'opposent à la vaccination de leurs enfants ou bien qui s'opposent effectivement dans la prise de la CPS. Donc, c'est quelque chose qu'on continue de travailler dessus et ça fait partie des observations faites post-campagne et on pense que la nouvelle stratégie de communication prendra ces aspects en compte. On va faire une étude de terrain pour voir les barrières analysis pour pouvoir adresser ces facteurs-là.
Merci. Il y a quelqu'un qui a levé la main en ligne. Je pense s'il nous entend, vous pouvez poser votre question. C'était qui? Ok, docteur Condé, vous nous entendez? Ok.
Peut-être que le docteur Condé voulait apporter plus de précision parce qu'il fait partie de ce groupe de mise en œuvre de la mutualisation, certainement.
Et peut-être il peut écrire dans le chat son intervention qu'on pourra peut-être inscrire ici. On a fini la session de questions-réponses. Il n'y a pas eu beaucoup de questions. Merci beaucoup à tous et merci d'applaudir nos panélistes.
Great, maybe I could just ask people to, we'll go for a coffee tea now. And if we could come back and be in this room at 4:20 for our closing session. Sorry, 4:20 for our closing session. I just wanted to thank our moderator, Asha, from UNDP Chat. Excellent session. Thank you very much, Asha. We'll see you in 20 minutes. From Dr. Marcy. So Marcy, let's let a few more people come in because I think they are coming in from outside. It's important that. You sure? Okay.
Hi, everybody. Still awake? We got one more presentation, a few awards. So I wanted to start. We last met in person in 2020. And when we last met, there was an AMP team of Marcy, and that was about it. So in the time since we last met, I have a team. And I've actually had a whole team, and one person's actually left the position since we met last. So I just wanted to ask Eliza, Robert, Zainab is only online, and Giovanni to stand up. So this is the new AMP team at the back, somewhere back there. So Giovanni was really focused on the New Nets project. So thank you to IVCC for that investment that supported us moving technical assistance during a very, very difficult period for all of you and for all of us. Robert is focused on information systems and M&E under our Gates IT and campaign efficiency project. Elise is our AMP coordinator. And then Zainab Ali, who is online, is our senior malaria technical advisor under our Gates project. So just to say to that team, it's been a rough couple of years, and thank you for your work. And I'm sure everybody in this room appreciates you having been there. So for slides, how do I do? Okay, so we started with numbers, and now I have numbers. And I think you should trust my numbers personally. So these numbers are actually from John Milner from the end of the 2022 data. So as you can see, we're at about 260 million nets that were shipped out to sub-Saharan African countries, another just over 23 million to the rest of the world. And in 2023, we will pass the 3 billion nets shipped out to malaria endemic countries since 2004. So while that seems like a big achievement, it's also pointing to the need for us to focus a little bit on our waste management and other practices, because I think all of us driving in any country where nets have gone out can see them all over the environment as much as they are in houses. Okay, these are my numbers, and I think you, again, should trust my numbers. There were 35 countries with planned campaigns in 2022. I have data for 31 of those countries. Of those 35, AMP worked with 22 of your countries in 2022. There were 236 million nets planned for campaign distribution last year. 191 million distributed. These are not the exact numbers. We do have exact numbers. So that's 81% of planned nets distributed. And that's a huge achievement. So please give yourselves a round of applause and thank you. Of the campaigns that missed, there are two big ones, two countries that missed. One is India. So India missed by about 12 million nets. So when you look at the difference, and the other one is DRC, where we've seen a huge amount of work in 2022, but it was moving 2021 campaigns that had shifted because of the delays with the transport due to COVID. And so now we're moving some of the 2022s into 2023, but it's not for a lack of effort of any of the programs that we did not see 100% of those nets go out. And then coming back to our first presenter on day one, no matter how many nets we're putting in, we're not achieving our targets. So our levels of use and access remain at the 2017 levels. And now you get to go to work. So you should be able to go on here. And what I want you to do is you're going to all put in some suggestions for us as a partnership. So for you, having been here for 2 days, our first in-person meeting in 3 years, what do you see as the priorities for AMP? Where do you think we should be focused for 2023 and 2024? And I'm going to put the mic down for a minute and let you guys do that. And at the end, we'll open up the word cloud and see what we've got. So I'll give you guys 2 minutes on that. And you can enter multiply. So you have 3 the first time, but you can go again and do 3 more. You can do it as many times as you want, and it will be open throughout the whole presentation. So you can continue to put things in as we move. Sorry, the other country that missed, I don't have data for, and I don't know if they missed, is Afghanistan. And that's another almost 5 million nets, but I just don't have an update from them. They could have gone out, maybe not. Okay, I'm going to keep going while you guys are doing that. This is one of my priorities. We need some new photos. We're running out of photos like badly right now. So like when we put out guidance, they're all the same photos and we can't find photos for awards. So we'd really appreciate if you could send us photos of anything, basically, and just give us a photo credit and allow us to use them for the guidance moving forward. If you look at our, we put out one guidance document that 100% of the photos came from Guinea, like we're really out of photos. I think we've talked a lot about this. The challenges are enormous, and I don't think they're going to get smaller over the short term. I think these 2 are probably the biggest ones that people are thinking about right now. So we consider as the AMP partnership that the vector control space is getting a little bit complex, not just for operationalizing, but also with the number of partners that are currently engaged. So I wanted to reiterate that AMP will remain focused on its core mandate, which is the coordination of partners through the weekly call, the development and dissemination of operational guidance based on identified gaps in iterative learning, and the provision of technical assistance based on requests. So I wanted to make sure that we were clear that AMP will remain in its lane in terms of the work we're doing to support the programs. And we are grateful for the trust that the programs show in AMP. So this has come up from many of the programs, so I wanted to touch on it. You know, we provide TA, many of you get TA. We have had a differentiated model of TA for the last couple of years, so thanks to the UN Foundation and the Gates Foundation. Some of you are still on a full TA model, so meaning you get 30 days in-country support, some distance support, and these are generally funded through RBM or Global Fund Service Provider agreements. But what we have been able to put into place, and this is for countries that are not looking for an intensive TA, but just looking for, can you review our plan? Can you participate on a few calls with us? So these really kind of lighter asks that the mechanism for full TA would take you 7 days, basically, or 4 days to get 4 hours of support. So this has allowed us to basically be more flexible in responding to your requests and making sure that our technical assistance is tailored to what programs are actually requesting and what they need. So the light touch TA can be hours or days over a series of months. So that's really been useful for a number of the programs in here to just request sort of some easy TA. So I think 4 different national programs talked to me about this last night. So I'm bringing it up here. We are working to identify staff from national programs to support other countries with their campaign where nets are needed. Like your urban area is not uniform, right? It's also extremely heterogeneous. So when you're looking at it, there are places you might need to do a campaign, but do you need to do it everywhere? Do we need to talk about investing more money to get to the minister's house so he doesn't complain because he didn't get a net that he's never going to use? I think we need to start to think very rationally about how we're using very limited resources. Okay. Some of these messages I think I've been passing, I went back to some of my old slides and my key messages aren't changing too much. So maybe you guys need to do something different. I'm not sure. So support the continuous distribution scale up. I mean, we need to get beyond pilots. There's enough evidence. Tanzania can go to your country anytime and talk to you about school-based distribution. So if you want to invite Tanzania, I'm sure they'd be more than happy to go and help you out. If you want to invite Ghana, they can probably go and help you out. So there are lots of countries with experience on this. And I think we need to improve on our exchange between countries on information and what's working and what's not. So again, within that, we could move people from one program to another for observation missions. CD will be one of the focus areas for us for programs. It won't be to go and see a standard campaign, okay? This has been talked about, Angus hit on this. I think the biggest issue we have now is trust. That's trust at the national level, but it's also trust at the household level. And I'm very sorry for the Pakistan situation where those nets went out, because when you go back again, people may reject because you gave them a substandard product. And so as we distribute substandard products, I think we need to recognize that there will be implications down the road on how much SBC you're going to have to do to make people accept a new net if it's still not what they're looking for. We will work with you to support on the post-distribution monitoring frameworks and operationalization of those. So we will work closely with Angus, the I2I and CHI teams, as well as Hannah to support on this issue. Hannah, over to you.
Just a quick reminder on textile. We are absolutely aware that countries have preferred textiles and that preferences for textiles may vary subnationally, even neighborhood by neighborhood. So as a reminder, we have looked and made an entire website for country data, looking at the proportion of nets that are used according to their different textile to help you decide whether you have a problem in the first place and then the size of that problem in terms of the outcome of net use. Now, we also recognized that textile can affect things before the net gets into the household, whether it's picked up at the distribution point, and then how well it might be kept or handled depending on the preferences of the household and the availability of other nets that they may have access to. So I just want to emphasize that we are looking at this in conjunction with a number of different partners at a number of different time points along the net life cycle so that we can discern what else is happening with preferences generally, but more specifically on textile.
And just to plug that if you do think this is an issue, like you think that people are not coming to pick up your nets at distribution points because of the textile, write to us. We'll help you figure this out, okay? Because we do agree that it can be a problem. So what this data is showing may not be reflective of everything that's happening at the country level. Thank you, Liberia, for this beautiful photo. So I think we need to think about feasible waste management, and it's going to be really a country decision. Do you need policies on net care and repair and what you're doing with end-of-life nets, or just some level of procedures of what you're going to do? But right now, what we're seeing is it's very, very nebulous what you're doing. So we also know that we develop very nice waste management plans, but their implementation, we feel, is maybe not where it's supposed to be. So we need to talk about this issue, and we need to be honest about this issue, and then we need to find solutions for what you're facing at the country level. I think, you know, we can pretend we're doing this perfectly, much like urban distribution, and we are not. Okay, this is a really key message for me this year, just seeing some of the delays we're having with campaigns that are moving to digitalization. It is not one size fits all. So when we talk about what happens in Nigeria stays in Nigeria. It doesn't have to stay there. But more the issue being that the Nigeria system was designed to address Nigeria's problems, right? It wasn't designed to address Liberia's problems or Madagascar's problems or Pakistan's problems. So, I mean, identify and prioritize what you're trying to improve and make sure that digitalization is a way to improve it. I mean, digitalization isn't going to improve, for example, that your IP and your program don't work together. That's not going to solve that there. Assess your context and see what you have and what's feasible. Because again, what Nigeria does and what DRC does may not be what you can do. And then ensure the interoperability with the existing systems when adopting a separate platform. Most of you want access to your data more or less immediately, but some of the platforms you're using don't allow that. And so you need to figure that out early, not at the end when your data is stuck somewhere and you can't get it. The really terrible picture on the right is the digitalization decision-making matrix. It's a tool, it's on the website. It asks you to walk through different questions. It prints you out your results, and then you can use that to discuss what might be your needs and what platform might work for you. There's a risk assessment and mitigation plan and a planning and budgeting checklist in that tool. Chris. I'm over to Chris now. I'm multitasking. So from my side, I'm going to hand to him. The objective of GS1 is clear. We work with all of you. You keep telling me we're not doing this, but we're doing this. And we don't know how to do it, but that's okay. And this system interoperability needs to be considered. But I want Chris to talk because you guys keep telling me we're not doing this, but we have to.
Thanks, Marcy. So yeah, I'm looking at the title of your slide. So it's operationalizing GS1. GS1 is a standard. What that standard has been used as the basis for producing consensus across manufacturers and the community in terms of what information we want to have systematically, routinely conveyed on nets, net bags, and the bales in order to identify what it is and be able to then improve tracking, tracing, and authentication. So it's an enabler. It's there. If you don't even scan it, you can read one label across multiple manufactured nets and identify these key components that basically says, this is what I am, this is where I came from, this is when I was made. We need to do that more.
And so on our side, I just keep calling this, you're going to have to scan barcodes on bales. I don't have any technical language, but I don't think we understand what it means. Like, how many people do you need? And I mean, can we make a ratio of if you have X number of bales, you can scan this many every 5 minutes, and therefore you would need this many people. How many devices do you need? How much time, more or less, will it take from normally what you're doing, just checking off on a tally sheet? Data visualization and access. So these are all issues that I think you need to think about. And one that came up very strongly in Sierra Leone, they are going digital, but for the barcoding, they want it into their national system, so their M-Supply system, but the two platforms are not interoperable. And so again, these are the things that are creating some of the delays in rolling out campaigns because our systems aren't actually talking to each other to be able to use the data where we want it. I'm just not even going to say it anymore. This is it. I mean, we're seeing 6 to 8 month delays on decision-making around digitalization. This is pushing your campaigns past the rainy season, your high transmission season. If you want to digitalize, start early. Take some decisions as a program on the basis of what you need to solve and get it done and not leave it to the last, because I think we're running into very, very big time pressures now. And training beyond the device will calculate automatically. The human error is still a factor. If you have 4 people in your house, the device will tell you 2. If you put 10, it's going to tell you 5. So if there were 4, you just over allocated, even though the device told you the right number. So don't forget the human factor when we're talking about digitalization. Okay, and then we have lots and lots of data. I think Hannah's pointed this out. I think lots of people have pointed out, there's a lot of data available now and across health programs. So when I look at the work that Nigeria will present on tomorrow, you know, we tried to leverage the grid 3 maps from immunization for the program to see if that would work. And we had a lot of challenges with it, but it was an effort to reuse data rather than recreate and reinvent the wheel. They'll present on the lessons learned from that tomorrow, but I think it's really important that we start to talk about this. We still see some countries doing in March SMC microplanning and in April net microplanning. And I'm not totally sure if we need to go to the field twice for that, or if there's a way that we could figure out how to gather all the data from the same people who are going to be in all of those meetings in a single visit. So start to think about this. You have lots of data, use the data that you have and figure out what the other programs around you have, because immunization is quite far ahead of us on some aspects, including on the use of geospatial maps for targeting interventions. So we had this at lunch today. This remains a major focus for us. And as Jason and Joe and Jess announced, we are looking for co-chairs for a new working group. The results are really great in terms of inclusion of IDPs and refugees on paper. Maybe a bit less great in terms of how we're operationalizing that. We have countries that still haven't reached populations for a year that should have received nets, but they have no way to do that. And just encouraging everybody to leverage on the community health system. In almost all of your countries, there's significant investment going into community health workers. And yet in many of those countries, those are the last people who are chosen to be your household registration personnel because you want to reward and give money to somebody else. So I think it's just important that you've invested in these systems and they're there for a reason. And those are the systems that you can use to reach your last mile populations. There's some persistent challenges. So fixing the denominator, which we will be speaking about with on Friday and Saturday in the meeting that will happen. Using the geospatial maps within the planning and implementation to try to get to all of the populations we're targeting. And then, I mean, I don't need to say this to you, the non-technical issues are killing us right now, right? If I take Pakistan, you know, it's a procurement issue. If I take Madagascar, it's a payment issue. So, you know, these things they're difficult things to solve, but the implications on the program are enormous, right? And we also know you can do payments to 95% of people can receive that mobile money, but the 5% who don't will be the loudest and most vocal people in your whole country until they get paid, right? And that problem will never end up at an implementing partner's door. That problem will invariably end up at the program's door and at the district level's door. So make sure that you as a team working on your campaigns get this right, because when we get it wrong, it has some serious implications for the programs. Okay, and now we can go to your Menti results. That's all I have. And if you didn't enter anything, I'm going to make you redo it. What'd you come up with? Ooh, good stuff. Lots of stuff. Okay, it's good to see that we're relatively aligned. I'm glad when my priorities match the programs. It means we're listening. I'm listening to you. I see quality assurance, obviously waste management and CD coming up very, very strong. Great to see integration coming up. For countries that want to actually do co-deployment or full integration, you need to start earlier than you start on thinking about digitalization. You know, when we started doing integrated campaigns, all of your donors and funders were on one page on how we were going to do that. They're no longer there. So if you want to integrate immunization and nets and something else, you need to get your donors all aligned on some type of single reporting that you can do. Digitalization is still there. I see capacity building is there. coordination, the ABC model. Very nice to see that people have taken the ABC model on. It could make your life easier. Okay, so this is great. And I'm going to stop there because I am between us and the end of the day. We will use this word cloud moving forward, and we will let you hold us accountable for what goes into our work plan. And when we come back in a year, we will present back on what we've done against some of these priorities that you've identified. Feel free to keep adding things to the Menti. We won't close it down, but this will really define our work plan for 2023-24. So I am grateful to all of you for your contributions. Thanks.
Good. We are now going to start the award section of this meeting. I'm going to invite Hannah to come up with the capes. And this is something that Drake Zimmerman would normally do. Drake is online, but unfortunately he wasn't able to join us. So we have a series of capes, and I'm going to let Hannah start. You're going to hand over the first cape.
Bonsoir à tous. J'ai l'honneur et le plaisir de reconnaître le Gabon pour une cape parce que j'étais volontaire de Corps de la Paix au Gabon il y a 20 ans et aussi, plus important, le Gabon se lance dans une première campagne avec le soutien et les conseils de AMP. Et ils sont déjà très partants, très motivés et très communicatifs. Et on veut reconnaître cette motivation, cet esprit de travail et de collaboration. Donc, les participants du Gabon, Gladys, Alain, vous êtes là? Oui, venez! Donc, c'est pour vous encourager dans votre campagne et tout ce qui est lutte antivectorielle.
Do you have a camera? Can anyone get some photographs? If someone, yeah, that'd be great, just use mine. And we'll put these up. Great.
So it's my turn. We're going to be presenting a cape to someone who I think he is a great guy. He will look good with the cape wearing it this way, but we know he will use it sometimes to actually put it in front of himself to escape the hard questions. Dr. Patrick Okello of the Global Fund.
Susie said she loved the award.
Where's this?
Yes. Yes, you put it on. Yeah, plastic. It's a plastic race. Pass that over there. Pass that over.
I put it on top of him.
Yes. Good. Well, I have the honor to present the next cape. And yesterday, near the end of the day, we had this presentation, and everyone at my table was like, "This is a great piece of work. And this is really, really impressive. It reminds us of what we used to do as a partnership when we started out." So I'd like David from MCD to come up. We're just very, very impressed with your work and data-driven decision-making. So come on up, David.
You got a cape? Put that on you, my friend. Here we go. Wait, I'll just put the little clippers so you can actually put it on you properly. Oh, boy. You have to leave that on, I think, so then yeah. You could turn around and do the whole.
Okay, I am going to present the next award, or the next cape rather, to someone who has been instrumental to the next 2 days of the meeting on campaign digitalization, working across all partners and making this a reality. This is Robert.
All right, so this is the last but not least cape. This is to a project composed of many individuals, some of whom are here today. And just in great appreciation for all of the data, the information, reaching an exit price, reaching volume guarantees, having a policy recommendation. So to the IVCC team and the New Nets project, great appreciation for all the work that the project undertook. Thank you.
And if I could just ask members of the core group, the exception of Marcy, to pop up onto the stage. We as a core group with Drake wanted to make a special award to Marcy. So in previous years, Drake's given Marcy different Wonder Woman, Miss America costumes. Some were Halloween costumes, clearly. I think one time it was an adult pleasure costume. It was a bit shaky. This year, it's a much more conservative but reasonable award. So we really wanted to give this to Marcy on behalf of the core group. So come on up, Mars. Can we just get a photograph, Mars? Great, congratulations. And then, yeah, that's all, yeah. And Mohammed, can you come on? I'll let you speak and then I'll give you one of these ones.
For Sudan?
Yeah.
Yeah, this. So first country award goes to a country which has completed its first single national campaign for the first time in 2022 and distributed more than 18 million bed net in a difficult situation. And this country is being first time awarded by ANP. So Sudan team. Yeah.
So obviously the Sudan team with the current situation in Khartoum is not able to travel, but we just wanted to congratulate them. Dorothy, do you maybe want to come up and get a photograph? Great. You and Mohammed, you stand there.
Bonjour à tous. J'ai également l'honneur de récompenser un pays pour un extraordinaire travail pendant ces derniers mois. Et je pense que vous le savez, depuis quelques années, l'AMP donne 2 prix au nom de 2 partenaires dans la lutte contre le paludisme qui nous ont malheureusement quittés. Donc, j'ai le plaisir de présenter le prix du leadership du corps groupe de l'AMP en l'honneur du feu Dr Samuel Smith, l'estimé directeur du programme national de lutte contre le paludisme de la Sierra Leone, qui a travaillé sans relâche pour lutter contre le palu, en particulier pour les enfants de moins de 5 ans et les femmes enceintes, qui sont particulièrement touchés par ce fardeau, comme vous le savez. Donc, le prix du leadership cette année est décerné au docteur Mohamed Saleh Issaka Diar et à toute l'équipe du programme national de lutte contre le palu du Tchad pour la première fois. Félicitations au Tchad. Je veux également rappeler que le Tchad est reconnu pour avoir mis en œuvre avec succès cette campagne de numéralisation menée à l'échelle nationale, dont la première phase vient de se terminer. Donc, félicitations. Vous avez réussi à introduire de nouveaux partenaires à la campagne sans délai, y compris l'AMF, qui n'est pas simple. Donc, félicitations. Et vous avez fait tout ça avec vraiment un appui technique limité. Donc, on est vraiment fiers de vous. Félicitations au Tchad.
OK. Et comme d'habitude, j'ai le dernier prix de mérite pour cette année. Donc, je veux demander Dr. Joris et l'équipe de la RDC de venir ici. En tant que pays qui fait une digitalisation assez spéciale, sans beaucoup de réseaux partout, contrat sur la base des activités, utilisation des données. En fait, ce prix, c'est pour l'utilisation des données, pour la prise de décision. Et donc, on va faire, et c'est au nom d'une collègue qui est décédée depuis quelques années, mais c'est vraiment pour la prise de décision sur la base des données. Donc, félicitations à l'équipe de l'RDC.
Good. And then just a few final thank yous. And I would like Oriane to come up to the front. She's going to hate this, of course, because she's at the very back of the room. But I think all of us have been working with Oriane over the last weeks and months, and she's really done such an exceptional job of pulling together this meeting in a very, very short time frame. And it's really, really been impressive work. So actually, to start with, you know, we interviewed Oriane a few years back. She was a new mom. Come on up. And she talked about her son. And so the first awards are for Antoine, her son, who is the first time Oriane and Antoine have been apart. So a little Superman cape and a Superman thing. But then Oriane, on behalf of the, hold it up. It's a little tiny cape. On behalf of the partnership, this is just a thank you to say thank you for all of the organization for the meeting. Thank you so much. Great. Right. And then our last award is actually for Eliza. So Eliza, do not leave. You know, I'm really fortunate. I share a desk with Eliza. I practice my terrible French. She giggles and be like, that's awful, Jason. This is the right way to say that. So I share a desk with Eliza. We work together very, very closely. But you know, the work of this partnership, the conference calls, the weekly minutes, all of that stuff, it's Eliza that pushes all of that forward. So much of what we can do here is really driven by Eliza. So Eliza, we just wanted to thank you. Got you a little gift from Kenya. Come on. Thank you very much. Thank you. On est ensemble. Wait, gotta get a photograph. Good. So we will conclude. I wanted to thank all the presenters and all the session chairs over the last 2 days. It was an enormous amount of work to prepare and to present. So thank you very, very much. Also, I want to take a moment to thank our translators, the audio-visual people, and the people here at the hotel for very, very good work. So thank you on that. And I think of equal importance, the participants, both the people in this room and the people who've joined online. So it's a number of firsts as we talk about. It's our first meeting in a country with a disease burden. It's our first hybrid meeting, and it's the largest level of participation to date. So it's a really exceptional achievement for this partnership. So congratulations to everyone. A few other things, all the PowerPoints will be on the AMP website, probably by the end of the day today, but if you don't see everything there today, tomorrow. And we've just received the evaluation email. So we would really, really appreciate if you took time to do the evaluation, and there's sections there where you can leave text just to help us improve this meeting for future years. And this is, it's funny, in health and care, I mentioned at the Federation, there's a number of partnerships, but I think there's something very, very unique with this partnership. And it's really the power of the people in this room that join the calls on a weekly basis, that invest their time and energy in this partnership. It's really impressive. This partnership has changed every single year, whether it's due to changes in funding, expanded needs, COVID-19, but each year I find it has strengthened and it has positioned itself to continue to improve going forward. We have to acknowledge Marcy for a lot of that work. So thank you, Marcy, but it really is the power of the people in this room. So thank you very much. I think about 90% of the people here will be with us tomorrow and the following day for the campaign digitization meeting. So we're not going far, but thank you very much. And we look forward to speaking on Wednesday of next week for the weekly call. So thank you. Oh, and one last thing, the hotel found this key card in the men's bathroom. So I sanitized it, knowing men's hygiene practices. But if you've lost your key card, I'm just going to put it here on the counter and you can come up and grab it. Thank you.